Well, here we are again. Really sorry for lots of the technical issues. I'd like to introduce Annie Patella. She was the keynote speaker we were expecting this morning, but because of technical issues, we weren't able to connect with her. So Annie, I'd like to introduce you. Maybe people who were watching before, they will have already seen you, but some of the new people joining us won't have met you yet. So Annie is a senior technical officer at WHO in Geneva. She has loads of experience, over 20 years experience working in maternal and newborn child health, with a particular focus on access for care for underserved populations and women, and also community participation in the design of health programmes. So Annie, without further ado, I'm looking forward to what you're going to talk about, and we'll see how many questions we get at the end. Well done. Good luck.
Thank you. We're going to try this again. This is a little deja vu now, but thank you for joining. And apologies for the hiccup this morning. Let me start by saying a big thanks to the organizers and how well they've handled the hiccup, maintained their calm, and helped me to maintain calm. So happy to be with you. This presentation, again, the idea wasn't that we talk about implementation research with this presentation, but rather take you through respectful maternal and newborn care. And we'll start by colleagues from SRH, Hediye and Oske, who lead the work in another department in WHO, and they'll give you some of the conceptual background about maternity care. And then we'll hand over to Emma Sachs from Johns Hopkins University, and she'll talk about integrating newborn and making sure that newborn is an integral part of respectful maternity care. And then I just want to quickly go over with you and leave you with some of the implementation challenges we've seen. And I hope my main purpose is that in your next sessions and as you participate throughout this conference, hopefully you can think about these challenges in light of implementation research and how you would address them in your upcoming work. So can we go to the next slide and to the presentation by Hediye and Oske?
Hello, this is Hediye Mertosh, and I'm really excited to be presenting WHO's research on respectful maternity care. So as many of you know, the issue of disrespect and abuse was really highlighted by the Bowser and Hill landscape analysis in 2010. This eventually led to the WHO statement on the prevention and elimination of disrespect and abuse during childbirth in 2014. And since then, there's been various ways to frame this issue and various terminology used, starting with obstetric violence in Latin America, and of course, as I just described, the disrespect and abuse terminology that initially emerged, which led to mistreatment, which is the terminology that WHO uses to describe this phenomenon based on the 2015 systematic review. And also evolved into respectful care, which is a broader concept that encompasses mistreatment during childbirth. And so the typology of mistreatment conducted in 2015 was 65 studies from 34 countries, including the following 6 domains. Based on this typology, WHO led the multi-country study on how women are treated during facility-based childbirth, given that there had been no global level effort to systematically define, measure, and prevent mistreatment. Therefore, the objectives were to develop and validate tools that can measure this phenomenon, but also to explore factors that are associated with mistreatment during childbirth in facilities. Phase 1 involved qualitative research to explore what constitutes mistreatment across the 4 countries in the study. The protocol has been published, and also the evidence from the countries. Phase 2 was really the tool development and measurement phase. It was really a mixed method approach to develop 2 tools that you can see here, the labor observation form and the community survey tool, that are now publicly available online, and the methods are also published. So really the results were published in October 2019 on the measurement phase, from the measurement phase, and it was again, using the 2 tools, the labor observation and community survey tool, and it was really collecting data on women's experiences of mistreatment and also sociodemographic and obstetric history. And I'm going to briefly go over some of the results. So just an overview of the sample, approximately 2,000 women across both tools. In terms of some of the key findings, as you can see, this is the domain for physical, verbal abuse, stigma, and discrimination, which across both tools, across 4 countries, you can see the results. And I just wanted to highlight the importance of timing. And so here we looked at the timing of when physical and verbal abuse occurs using the labor observation, and it was really between 30 minutes before birth to 15 minutes after birth that this peaked, and women were really at an increased risk for both of these phenomenon during this time period, which is critical to address. In terms of other areas, such as informed consent, across procedures we see non-consented care, with the highest being among episiotomies, both picked up by the labor observation tool and community survey tool. So you can see the results here. And in terms of consent and confidentiality, taking vaginal examinations, looking at vaginal examinations, over half of the women both reported and also were observed not to be consented or have their vaginal examinations conducted privately. And we saw that simple measures such as curtains were really are really key to prevent mistreatment and allow women to feel that they were private, given that women who reported no use of these measures were 3 times more likely to report lack of privacy. And also risk of non-consented care was seen among unmarried women and younger women, which brings us to the point that really factors associated with mistreatment include vulnerable populations, between vaginal examinations and also other areas of mistreatment, of the mistreatment typology. And so it's really important to tackle these key vulnerable populations when we're addressing mistreatment during childbirth. In terms of the evidence, we've been fortunate to translate some of our evidence to national recommendations on respectful maternity care in Guinea. Based on the published evidence from October 2019, stakeholders in Guinea came together to develop recommendations based on the findings, their national findings, and adopted them in their reproductive health plan. And this is really an exciting turning point to see research being translated into practical recommendations on the ground. We're also excited to be measuring mistreatment of women in the WHO EMRO region, a region where there's really limited evidence on this phenomenon. And so the occupied Palestinian territory is leading the effort in 3 regions, Gaza, Hebron, and Ramallah. The training was conducted right before COVID, and since then, however, we've had to amend. The data collection methods have been modified, however, the study is ongoing. There's a number of secondary analyses using the study that we're also working with our country teams and colleagues to work on. And this includes some analyses on newborn practices, such as 15 observed practices from the labor observation tool, and among many others. And next, WHO is really looking to reduce mistreatment of women during childbirth, and really to understand what interventions are needed. And of course, there's no one magic bullet, and so we're currently looking systematically on scoping, systematically looking at the evidence through scoping and systematic reviews to better understand this. I hope this was a great presentation. Thank you very much for your time.
Great. So a virtual applause to Oske and Hediye for orienting us. All those tools are available online. And now we're just going to pass over to Emma. Emma, just note the slides on the screen might be different from the last set you sent me, so beware. So Emma's going to talk to us about integrating newborn into respectful maternal and newborn care. You may be on mute.
Hello? I'm not on mute from my side.
I can hear you
Can't
now.
hear me?
So I can hear you, so I'm hoping the rest of the world can hear the two of us. If any of the organizers want to say something so we know someone's listening to us, that would be great.
Yes, we can hear you.
There you go. Okay, Emma, over to you.
Thank you. And thank you again to the organizers for putting this together. Thanks to Annie for inviting me to speak more about integrating newborn into respectful maternity care agenda. I don't know who's advancing the slides. Can
Just say
someone
next.
advance? Next, thank you. Sorry, they're tiny and blurry, so I don't know what they say. So hopefully they're close to mine. I apologize for this. There we go. Thank you. So anyway, thanks again for everyone for joining and sort of taking part in this discussion about a really important topic. I think we can all agree respectful care sort of should include everyone who is seeking care at a health facility. And we have some anecdotal evidence that there's mistreatment of newborns or kind of negative experience of healthcare that newborns are having at health facilities, but there hasn't been as much attention kind of on the systematic research side. And obviously that's important kind of for the care of newborns and their families, and it may also be driving low utilization when the costs for seeking care are high. Next slide, please. So the terminology of respectful maternity care was always intended to include newborns as well as families and healthcare workers and everyone kind of participating in that maternity experience. However, as I mentioned, there hasn't always been the same level of attention to newborns. And part of that is because newborns have limited communication ability and depend on parents. However, we know that many women and newborns are cared for by the same providers in the same facilities, and that many of the rights are shared by newborns and their families. So not being separated is sort of both a right of the newborn to be with their parents and the parents to be with their baby. Similarly, the right of a newborn to have their legal guardian consent for their medical practices, a right of the parents to consent for the medical care of their newborn. Next slide, please. So you heard already about the typology that was developed for looking at mistreatment of women. I conducted a literature review a couple years ago to see if there were occurrences of mistreatment of newborns that fell into these categories. And unfortunately, there were in most of them. There were also additional kind of categories that we thought were important around legal accountability and around bereavement after a stillbirth or neonatal loss. So I think there's some more thinking to do around what these themes might be or how they might need to be expanded when we're trying to document kind of various experiences for newborns. Next slide, please. So there's quite a bit of ongoing research just starting out to try to build out some of the evidence around newborn experience of care. And a lot of it is around kind of what are the types of experiences and the prevalence of various types of mistreatment or negative experiences that newborns have, as well as are certain groups more vulnerable to mistreatment than others. These might be characteristics that are shared with the family, such as being poor or from an ethnic minority group, but they also might be characteristics of the newborn that are unique and independent of the parent, such as being female or being small and sick. I think there's some sort of difficult gray area around what might be poor quality of care that maybe everyone in a facility is experiencing versus some disrespectful and discriminatory practices, and that can be difficult, I think, to disentangle, but we're starting, I think, to try to talk about what those various aspects of quality look like. Very importantly is how do people conceptualize newborn experience of care or mistreatment of newborns, and that includes kind of mothers and families, as well as the providers themselves and other people that work in this field. And so I think understanding that will help us develop what are the domains and how much do they overlap with those developed for women. There's an ongoing scoping review to look at tools that might be available or components of tools that ask specifically about newborns that I think will also help us not just standardize our measurement, but also will help us build the framework into something a bit more complete that can help us understand this for newborns. Next slide, please. So you already heard about the WHO study on how women are treated during facility-based childbirth. And one of the components was a labor observation tool, which occurred in Ghana, Guinea, and Nigeria. Next slide, please. And within that observation, we were able to get data on 15 newborn care practices that occurred during the first 2 hours after delivery. So these include things like immediate skin-to-skin care and breastfeeding indicators, a number of kind of recommended practices. So we can see the prevalence of how many newborns are receiving the recommended sort of evidence-based care. We also are able to see some practices that are occurring that are not evidence-based or that are potentially harmful. These include the newborn being separated from the mother, routine suctioning, slapping the newborn, and then maybe some of the more rare but serious events, such as the newborn being left unattended or refusal to provide care due to inability to pay. Next slide, please. So I hope that gives a small taste of some of the things that we're working on to try to build sort of newborn experience of care and treatment of newborns into this agenda. And I think there's quite a lot of work to be done. So this includes developing tools that can be used at the regional and national level. And in order to do that, we'll need sort of global tools as well as a level of contextualization. So quite a bit of sort of qualitative work also needs to be done to understand how these might need to be adapted for various settings. And that includes those with additional needs such as humanitarian or crisis settings. I think there's a hugely important piece of work that's also just starting around the types of support that healthcare workers need in order to provide quality care to mothers and newborns. I know there's a lot of providers on this call, and I think, you know, the providers themselves want to provide high quality care. So this is sort of a partnership that we want thinking about. How can providers be supported to be respected themselves and then provide the most high quality and respectful care to the women and newborn who are seeking their services. I think there's quite a lot of continued advocacy and harmonization that we can keep doing. It's been wonderful to be able to work across sort of those that work in newborn, pediatric, and maternal care. And I think we all see that the agenda will be stronger the more inclusive it is and the more everyone can contribute to it. I think, was there one more or is that it?
That's it, Emma. Over to me. Thank you so much.
Thank you very much.
That was great. Thank you. Stay on for questions, please. So now I'm going to take you through some of the implementation challenges. And again, I've done several different implementation research linked to respectful care or components of respectful care. And so also in working with country partners, we've heard a lot now that countries are keen. I mean, the conceptual part is so important and the measurement part is so important, but countries are really keen to move on to implementation. So next slide, please. The first challenge is probably, or one way of moving forward is making sure that respectful maternity care is integrated into quality of care processes. And you may remember some years back, WHO launched the standards for maternal and newborn care and a vision of quality. Next slide, please. Where particularly starting with for maternal and newborn health, it gave the equivalent to the provision of care as it does to the experience of care, with effective communication, respect and preservation of dignity and emotional support being highlighted as three of the standards. And again, this is quite important. And what we've seen now, the struggle is working in quality of care is how do you have providers and managers equate what is sometimes deemed the soft skills and equate them with the same level of importance as they would give to these other more clinical skills. And that's probably quite, when in a quality of care process, of course, we don't do everything at once. And when we're designing our first steps and highlighting what would be the first measures to tackle, again, how does a system help incorporate and make sure that experience of care is considered in those priorities? And later on, we'll talk about some things that might help with that. Can you just go quickly to the next slide? I just wanted to highlight that this same experience of care has also been highlighted in the quality of care for children and young adolescents. And again, slightly different, but the same components of effective communication and meaningful participation, respect, protection, and fulfillment of rights, and emotional and psychological support. And the next slide. And you'll see now in the recently launched standards for quality of care for small and sick newborns, again, embedded in there is this respectful care. And I just wanted to highlight that, again, so embedded in your quality of care, that's a first to tackle, that's considered a priority. What we've really been struggling now is with the measurement. As you've seen from the past slides, a lot of the measurement has focused on what is mistreatment, what is abuse. A lot of the measurement is being done through research and scales. And so when we get to the quality of care processes, it's been quite a struggle to help countries identify those indicators and those measures that are already embedded in their system. So this is something, again, a challenge we need to think about and work on. How can we make this more part of their system? Or are we going to always be doing special studies? Next slide, please. So similar and related is the challenge of making sure respectful care is integrated into the normative work. Next slide, please. And one way, in WHO, we've started that, and I feel has been the tipping point or a change point, was starting our normative work from the perspective of what women want. And the antenatal care guides was a good example of that. I mean, research was done to pull together what is it that women want and expect from antenatal care, and then that helped guide and was included in evidence to decision framework. So not just looking at the results of is any intervention effective or not, but what are some of the important women's values and providers' values that need to be considered as well for the different interventions. Next slide, please. That also came up clearly in the priority questions for childbirth care. And again, this paper led by the brilliant Sue Down, focusing on matters to women, again, really helped to crystallize that women want a positive childbirth experience that fulfills or exceeds their prior personal, social, cultural beliefs and expectations. And there we just put some of the keys that came out from the research. Again, things that women want out of it. And that is so linked to respectful care, is responding to what she deems as priority. Next, please. So again, how do you operationalize respectful care for childbirth? In addition to avoiding mistreatment, abuse, some of the positive interventions, ensuring respect and dignity, clear communication by staff, a companion of choice during labor and birth, pain relief strategies, and mobility in labor and birth position of choice. Some of them providers are more comfortable with. Others, providers really feel are not their skills and maybe need more support to. And even looking at companion of choice, and we'll come to that separately in a minute, providers have their own barriers to implementing these types of interventions, and how do we find those barriers and help to address them. Next slide, please. So effective communication, again, is really a cornerstone for respectful care. I just put some tips there about what effective communication should include. This was included in the recent intrapartum care guidelines. But this communication between providers and women in labor, women during their stay in the facility or during childbirth care, using simple, culturally acceptable methods is what's recommended. And next slide for this one, just again to summarize the 4 recommendations that came out in the recent child intrapartum care guidelines, and that to me really, embody respectful maternal care and maternity care and the important interventions. Next slide. And I just want to take a quick focus on companion of choice during labor and childbirth. In the next session with Tina Lavender, I'll be talking a little bit about the implementation research we did in 3 Middle Eastern countries, Syria, Lebanon, and Egypt, to help implement companion of choice. It seems like a low-hanging fruit, but again, it's an intervention that providers, women themselves, have a lot of conceptions about. Can you just go to the next slide, please? Today, we've launched a web story on the WHO site, so please go to the site and find highlighting a new evidence brief, an evidence to action brief that came out. There's the link, and I encourage you to look at it. It includes a logic framework that we hope will help support implementation, but also help for advocacy and better understanding some of the key points. And the final point I want to make, next slide, please, and this came out a lot in the previous section, and probably Sally talked about it in her overview presentation this morning, but this whole idea of co-production. And again, respectful care, implementation research, we just cannot do it without embedding co-production into our processes. And again, it's something that neither researchers or neither implementers are very comfortable with. And learning to dialogue, learning to understand, and appreciating different knowledge and helping to put that all together is really one of the key implementation challenges. So, there's been different processes. For example, the White Ribbon Alliance and the campaign and listening to what women want around the world. It's just so important that we start with understanding what's important to women. Next slide. Also, in our work for WHO, for the Quality of Care Network, again, we've really struggled. How do we make this part of stakeholder and community engagement, hearing providers, a core part of any quality of improvement process? And the Quality of Care Implementation Framework does include stakeholder and community engagement as one of the key components. And when as we're working with the countries involved in the network, a lot of them said to us, we really feel we need support to bring forward this component. So we've developed a module, and with UNICEF and other partners, including Save the Children, World Vision, and other partners, we hope to bring it forward and be able to make that, just a really key step in quality improvement processes. Next slide, please. I talked about respectful maternity care and the charter and the importance of that, hearing women's voices, next slide, please. Women understanding their rights. The charter is so helpful for that, so that women, families, communities, and providers can see, what are women and newborns' rights, so that they know them and can help to protect them. And I'm going to go to my last 2 points. Next slide, please. And as passionately advocating to you to make sure women are heard, I also want to passionately advocate that you make sure providers are heard, and particularly midwifery and nursing providers when we're talking about respectful maternal care. As you know, this is the International Year of the Nurse and Midwife. Globally, 70% of the health and social workforce are women, and many of them are nurses and midwives. Next slide, please. They have to have a seat at the table. There were 2 efforts. One was a systematic mapping of the literature to highlight what prevents quality midwifery care, and hear from midwives what are some of the barriers they face. I think if you click again, something else should appear there. And there was Midwives' Voices, Midwives' Realities, a global consultation on providing quality midwifery care that captured midwives' perspectives on the challenges they face. Next slide, please. When we looked at the findings and put them all together, again, we demand respectful care, or we expect respectful care. We respect quality of care from a labor force that is truly challenged. And that's not meant to be an excuse. But again, if we hope to address quality of care and respectful care, unless we work with providers, unless managers work with providers, unless the research team, reaches out to providers and captures their perspective, we will not address some of the main barriers they face. And it's a difficult interplay of social factors, economic factors, and professional factors, and really embedded in gender inequality that makes for a difficult situation often for providers to, again, provide the care that we expect from them. I just want to take one last point on resilient health systems. Next slide, please. And I know there's been, the last session talked about COVID. Next slide, please. And again, as we are working with services, how do we support countries in maintaining essential health services for women and newborn? And as we're supporting them, again, COVID was difficult for health systems. First effort is to stop the infection, and but nonetheless, how do systems with all these demands help to maintain the services for these key populations, and in maintaining those services, not take shortcuts on some of the key components of respectful care. We've heard stories and read stories about women and newborns being separated and companions not allowed, and other what would be violations of respectful care. Again, how do we make sure that this is maintained during these situations that we're working closely with countries to address that. So I'll stop there. I hope I've given you food for thought. As you think out, next slide, please, just to say thank you. As you think about your implementation research and needs, I hope this helps to stimulate you. So over to you, Terry, and thank you again for inviting us.
Oh, thank you, Annie. I think for me, it makes me remember the conversation we had a few days ago, because it was the first time we met, and I think I should say first that I am actually a nurse and a midwife. I've worked mostly as a midwife. So, for me as a midwife, birth is the most joyful time for a parent, for a couple. And yet as a midwife, I would like to be able to facilitate that. But when I listen to my colleagues in many countries around the world, they tell me that there are no staff, there may be one midwife or one nurse midwife on duty on a night shift, and they're looking after 10, 12, 20 people in labour. So the system doesn't seem to allow or to facilitate care providers to be able to provide good care sometimes, because if you are stressed yourself, you haven't had a tea break, you haven't had your salary, there's no running water where you work, there's an electricity cut, the build-up of frustration and anger in the system that you're working in, how do we actually help and support our colleagues to be able to provide better care, provide this respectful care when they feel disrespected themselves? Yeah. Again, so Sally's words, and again, listening to Jane and Imelda in the previous one, co-production, planning, again, if we're going to use implementation research to address these kinds of barriers, I think planning came out heavily, and one of the things I wanted to add about it, it's proper planning, it's having the proper team, it's having co-production, it's also this learning component that was really important that I think is really difficult for researchers to accept. I think a lot of times researchers are used to having a protocol and following the protocol, and this idea of not having, being able to change and incorporate learning and improve what I'm doing is difficult. But really this part about I cannot address the barriers unless I work with women, with families, and with providers to better understand the barriers that are, again, social, systemic, economic, cultural, and all of them have to be addressed if we're going to achieve successful implementation. Now, we've just received thank you. So we've just received a really interesting question from Veronique, really sort of saying we need some success stories as well. We know the problems, we've known them for a long time. All our colleagues know them who provide maternal care. WHO knows them. This has been around for such a long time. But do we have success stories where it works? Can we start sort of disseminating the lessons learned, trying to see what works in one place, can it work somewhere else? Again, this is why I found it really important
important that I agree with you, Veronique, and I think all of us are frustrated that appreciate the need to start with identifying the problem, but really frustrated about moving on to the implementation. There are success stories, and it's time that we start compiling better, sharing them better in terms of scaling it up in a country and also moving to another context. You know, again, a lot of times implementation research can provide the best venue for doing that, because you do have to find what are the contextual issues, how do I work with them, and then how do I address them to scale up. But I definitely agree with you. Emma, I don't know if you'd like to say anything else to that point.
Just that I agree. I mean, I think that should be sort of part of our data collection, right? And part of our framing is to not only be looking for those instances of disrespect and mistreatment, but also thinking that the absence of that is not necessarily the same as respectful care. So what is it that's important to families, and being able to collect some of those positive stories, not just from families, but from health workers. What is it that enables the health workers to provide the best care in order to support them as well? I think those are really important sort of research priorities going forward.
Yeah. And from health systems, because again, it's not just, I mean, there are places where implementation has been successful. And again, we learned a lot in the implementation research on labor companions. So it's not just a matter of, it's at all levels. The individual woman, her family, and the provider, what are their, positive stories, but also what are some of the system stories where they've been able to implement and scale up. And again, kangaroo mother care work, we had work in Ethiopia and India, and I feel that's a respectful maternity care story. While the focus was on implementing kangaroo mother care, the effort requires that the mother, the woman, and the baby are together, and the mother is treated throughout the baby stay in the facility with respect and supported to better take care of her baby. And that is that's a norm change for a lot of places in after a baby's born with problems, and how we interact with the mother thereafter. So again, many dimensions to this.
So we've had quite a few questions about the support that we give to staff and how we empower them to be able to give emotional support to women, but also for themselves. And I think we've talked about this quite a lot, but there's been another question from Antenna in Melbourne, and he's asking, really, what initiatives does WHO have to promote the rights of midwife while also helping them to be able to provide respectful care, to train them well? What else can we do to help the people on the ground who want to provide this care?
Oh, I'm so grateful to this question, and so sad that my colleague Fran McConville is not on the line, because I very much suspected this would come up, but she was unable to join us today. And as I said, this is the year of the nurse midwife, and I feel like WHO and UNFPA together with ICM and ICN are really doing a lot to help support midwives. So not just only in advocacy, but that is a big part of it. Fran would tell you about a midwifery framework, improving the quality of education of midwives so that they have the skills they need, more dialogue, again, involvement of midwives and giving nurses and midwives a voice at the table. As you know, Elizabeth Ito, who is our senior advisor to Dr. Tedros, was appointed in the last 2 years. And again, the whole purpose was for highlighting the needs of and the importance of midwifery and nursing in health, and the importance of these providers in the health workforce. So I'm not doing justice to the response, and Fran will be very upset with me. Apologies, she's not here, but I will make sure that later on we share the link and see about how we can have ongoing conversations, because there is really a lot going on now. It's been recognized as one of the key the areas we've been negligent on, and unless we better support midwives, better support them in their competencies, and have policies that support them in doing their job. And again, all the different barriers they face in terms of safety, economics, gender, we kind of expect to see the improvements we're asking for.
I think that's really important. And I think, as you were saying, it's about how we actually help nurses, midwives become leaders. You know, that they actually promote their own profession, that they have that voice, you know, at a much higher level within countries, at a national level, to be able to say what it's really like on the ground floor, and to be able to say what they need to be able to do their job better. So I'm really hoping that it's a really shout out to everyone, really, that, you know, that we get behind the workforce and we really help them to be able to do a better job, because no one goes to work wanting to have a bad day. No one goes to work thinking, right, I'm going to shout at this person or I'm going to do this. It's that day in, day out struggle to be able to do your job, to actually get to work, then to, you know, you're faced with so much to do and so little resources to be able to do it. So it's about how we manage that as well, because it's, I think, you know, so many people, or the midwives I talk to, they really enjoy their job. When they talk about being a midwife, they are so proud of being a midwife. And it's about how we actually help them to be able to provide better care, as we've been talking about. So I'm looking at the other questions, and one of them is about the gaps between, you know, what about when we're trying to integrate maternal care and newborn care, what are the gaps, and how can we actually bring it more together so that we are working as a team?
Emma, do you want to start and then I can add, or?
Sure. I mean, so I think that's, you know, a good question in thinking about sort of how do we tackle this, right? And I think the way that a lot of us who've been working on this see this is just expanding the existing agenda, right? So not wanting to create kind of parallel initiatives, but really thinking about the massive amount of overlap that there is between sort of maternal and newborn care in this particular time period. You know, I think some of the, I wouldn't call them gaps, I would say some of the unique challenges around newborn treatment and experience of care have to do with the kind of limited communication ability of newborns, which isn't no communication, but right, newborns not being able to verbalize their needs and consent for their care in the same way that most, you know, adult or adolescent kind of females can do. So I think thinking about those challenges as far as making decisions in the best interest of the newborn, and what to do when there are conflicts, either between sort of parents or between the parents and the health worker, et cetera, you know, are important. I think we need to keep those in mind, recognizing that it's a smaller kind of percentage probably of the sort of, I don't want to call it amount of work exactly, right? But then in most cases, the needs of the woman and the baby and the family and probably the healthcare worker also are well aligned, right? So I think that can really be the vast majority. And then there are, I think, some additional unique challenges of newborn care that we do need to acknowledge and sort of continue working on, even though I think those are more rare. There are some kind of difficult pieces there. Annie, maybe you want to add more to that.
Yeah, I think you covered it well, and yeah, I mean, the movement started maternity care and the focus on childbirth care, and again, it was always intended that newborn be integrated. And then as we moved from, you know, looking at measurement into implementation, we did realize that somehow, though, there was just this look at more, you know, the mother and childbirth, and so again, we're expanding. You know, I'm just going to refer again to working with Kangaroo Mother Care. It also working with newborn care and in particularly small and sick newborn, again, if you look at the standards and what's come up, there are specificities for the newborn that need to come out. And two, it's not just the moment of childbirth. Again, it's a vision of how we treat the woman and baby and family throughout their stay in the facility. So it's not meant to be, I have respectful care for childbirth and then my newborn's sick, so I have to lie in a hallway, to be able to see the baby. It's, the whole time they're there, and any interaction a health system and a health service and a health provider has, that the components of respectful care for the mother, for the baby are incorporated. But I think you gave a really complete answer, Emma.
Well, I'd like to thank both of you. Our time has just about come to an end. I think that it's provoked a lot of discussion, a lot of thought for us, and I think it's really going to help move the conversation forward. So I think we have a short break. I know that we are running behind time. The next session starts very shortly. So please, everyone who's watching, stay online so we don't lose you. And if you're going to, you can go and look at the posters for a short minute, have a cup of tea, look at the soapboxes. Maybe, like me, you're going to go and try some yoga, and we will see you in a couple of minutes. Right, thank you very much.
The road ahead, it twists and turns, and the sun beats down and it burns. But I keep on pushing through. And every step quicker than the last, my feet tread down this beaten path, and I keep on pushing through. 'Cause I get up, and I may fall right back down, but your love lifts me back to solid ground. Yeah, I get up, and I may fall right back down, but your love lifts me back to solid ground. Oh, I've come too far in this to raise my flag and call it quits. So I keep on pushing through. Oh, with every step my heart it pounds. Yes, so sure I've had my doubts, but I must keep pushing through. Yeah, I get up, and I may fall right back down, but your love lifts me back to solid ground. twists and turns, and the sun beats down and it burns, but I keep on pushing through. Yeah, I get up. And I may fall right back down, but your love lifts me back to solid ground. You love you. Yeah, I get up, and I may fall right back down, but your love lifts me back to solid ground.
Good afternoon, everyone. Thank you for joining this session, and thank you for staying on for the afternoon session. I hope you've enjoyed the conference so far. This afternoon, I'll be co-moderating this afternoon together with Helen Nabuera. I just introduced myself briefly. My name is Dr. Charles Arme. I'm a senior clinical lecturer here at the School of Tropical Medicine, and I'll be co-hosting this session with...
Yes, so my name is Helen Nabuera. I'm a pediatrician based here at the Liverpool School of Tropical Medicine.
Yeah, so I'll just tell you the layout of we'll just run through the program for the afternoon. So we start off with 2 breakout sessions. So the first session will have 3 oral presentations hosted in one of the breakout rooms. So to join this presentation, after we finish the introduction, you have to click on the specific link in the app. The other parallel session running at the same time from 1400 to 1450 will be the NHIR Global Maternal Health Group panel, where we will have 2 professors, Professor Tina Lavender and Professor Dili Anumba. So if you're in that session, I'll tell you more about our complete panel. Then we'll have
We then have a series of workshops where we'll have more kind of like in-depth discussions about implementation research, just tying in what we did, we've discussed this morning. So the first one will be on creating new healthcare facilities. That will be with Professor Imelda Bates, Dr. Kathy Burgoyne, and Dr. Helen Allott. And then the second one will be achieving respectful healthcare, again with Dr. Annie Portela, Professor Salome Maswime, and Professor Tina Lavender. And the third one will be about achieving positive childbirth experiences, again with Professor Sally Theobald, Professor Indy Kaur, and Professor Andrew Weeks. So you're welcome to join any of those sessions by clicking on the appropriate links.
Yes, so after the first group of parallel sessions between 1400 and 1450, we will remind you of the instructions again, how to join whichever of the three breakout rooms that you like. We will end the day by streaming 4 very interesting Pechakucha style presentations. They're really interesting, and for this, at the end of this streaming these 4 excellent presentations, we will have a brief discussion about them. There are no questions to field. You can put text. The presenters can reply you, but we're going to do a bit of X factor here, where the audience has to vote. Polling will be open just for about 10 minutes, and then the best Pechakucha style presentation gets a prize from GLOW 2020 organizing committee. So good. Now I think we have all our instructions. So we're going to break out now into the rooms to run the sessions. So you can click the link to go into the oral presentations on implementation science now, or you remain with us on this channel for the NIHR Global Health Groups. Now, we have 3 members of the panel for this workshop, and one of them is joining us online. I cannot see Dilly online. Can you get him online, or does he only come on when he speaks? Yes. Hello, Professor Numba.
Hello.
Can you hear us?
Yes, I've been online, yes.
Good. Thank you. No, I just wanted to see you to confirm that you are with us. So I'm going to introduce members of the team. So sitting with me here in Liverpool is Professor Dame Tina Lavender. So she says she just waved. So she's a professor of global maternal health and has extensive experience conducting research in low-resource settings. She's also here with a member of her team, Tracy Mills, who is a senior lecturer as well in global maternal health. Sitting in Sheffield is Professor Dilly Anumba. He's a professor of obstetrics and gynecology and a senior academic, and he's also leading one of the NHIR global research centers. So I will, the way it will run is I will hand over to Professor Dame Tina Lavender, who will make a presentation combined with Tracy, and they show a video, and then they pass on the torch to Dilly, who will take over, complete the session, and then we can field some question and answer. So I encourage you to put in questions in the question and answer box for this session on the app, not in the chat. If you put them in the question and answer section, then we can pick them up and field to the team. So thank you very much, Professor, and you can make your presentation. Thank you.
Thank you very much. I'm delighted to give this talk on behalf of the team. So thank you for joining this session with us. I know that not all of you will be aware of what the NIHR Global Health Groups are. So I'm going to start off for the first few minutes just giving you a few slides on what it's all about. So just as a way of a bit of history, the National Institute for Health Research, NIHR, was established in 2006 to improve the health and wealth of the nation through research. And in 2015, the NIHR Global Health Research Group portfolio was established to support applied health research for the direct and primary benefit of people in low and middle income countries. And as part of the commitment by the NIHR was to produce these awards made available for research units and research groups. And these provide funding to researchers within universities and research institutes in low middle income countries and the UK who wish to establish new programmes of applied health research. We're currently in the third round, and there are various levels of commitment. For units, it's maximum of 5 years and £7 million is available. And for groups, it's maximum of 4 years with £3 million available. And the awards support delivery of research that will improve health outcomes for people in the low middle income countries and to strengthen the research capability in resource poor settings. So I'm going to focus on the research groups, and that's what myself, Tracy and Dilly will talk to you about today. But just to home in a little bit on their purpose is to address locally identified challenges in low middle income countries through equitable research partnerships between the researchers and institutions in the UK and ODA countries, to generate scientific evidence that can improve health outcomes for people in low resource settings through improving practice and informing policy, and to strengthen research and research management capacity and capability to support future sustainability of research in partner countries. So global health research groups are either new to delivering applied health research globally, or they wish to expand an existing partnership. And groups address unmet global health needs through equitable research partnerships. And the equitability is a really important underpinning concept of these groups. You must have joint UK and LMIC applicants, clear plans to strengthen that capacity, and must be able to support future sustainability in partner countries. To date, there are 3 research groups which are directly related to maternal and newborn health, although there are many others that have some relevance to them too. And you can find all of these on the NIHR website. But the 3 that are particularly pertinent to us today are these 3 listed here. So there's a group in Edinburgh, the Diplomat Collaboration, looking at preterm birth and stillbirth. And you can see Jane Norman in the picture there, who was the lead director. There's our own group, which I'll tell you a little bit more about. And then there's Dilly's group, which is PRIME, which is preterm birth prevention and management. So I'll just move on to our group and give you a little bit more detail. So this is our group, our NIHR group on stillbirth prevention and management in sub-Saharan Africa. And you can see most of the team here. We work across 6 different countries, which is Kenya, Malawi, Tanzania, Uganda, Zambia, and Zimbabwe. And a core principle related to our research group is that we have active community engagement and involvement. And there's been an awful lot of information already in the GLOW conference about co-production and engagement of women and families. And I would say that within our group, they have really informed everything that we've done from the start to the dissemination. So just to give you a bit of a background of why we're doing this, we know that globally 2.6 million babies die just before or during birth each year, and that the majority of these are in low and middle income countries. Stillbirth's a tragedy for women and families. There's long-lasting grief for their baby, increased risk of poor psychological health, and poor basic care and support. And as been mentioned before, I think it was in Kate's talk, in sub-Saharan Africa, over half of stillbirths happen during labour in association with preventable complications. So this means that the majority of those babies that die, we could actually save with the right efforts. So this map, many of you will have seen it from the Lancet series, which if you haven't seen the Lancet series, please do go and have a look. It's excellent. But this shows you the countries with the highest stillbirth rates and the highest stillbirth numbers. And I just want you to look at this for a second and just keep this in your mind when I show you the next slide. So from this slide, you can see that the darkest colours and the biggest circles are the highest rates and the highest numbers. Okay, so just capture that image in your mind. And also from the Lancet, this is a map showing the sites of the research into the impact of stillbirth. So you can see that there's a huge mismatch between where the biggest need is and where the research is being carried out. So these are the countries that we're involved with, and you can see on these flags the actual stillbirth rates. And I've also put up our own rates just to show in the UK, just to show the comparison. This is really testing your knowledge of flags here, but if you go along the top, it's Kenya, Tanzania, Malawi, Uganda, Zambia and Zimbabwe. And you can see that they're all around about the 20 per 1,000 births, whereas for us it is only 2. And you can see here that stillbirths really do count, and this is one of the important things that we have to realise, the impact on the women. And this is a quote from a South African artist. I'll let you read the quote for yourself. And there's many, many more of these out there. Women's stories are very, very powerful. But as a consequence of the stillbirth, 4.2 million women have depression as a result. So this is huge. So the aims of our group is to look at the main causes of stillbirth so we can apply interventions to prevent it happening, to explore why women do not receive appropriate labour care in a timely fashion, and to explore the best way to support women and families after the death of their baby. And to do this, we've used various approaches, and I don't really have any time to go into these in any detail today, but please do get in touch if you want to know more information. But this schema just shows you that it's a mixed methods approach that we used with retrospective cohort studies, mixed qualitative work, standalone qualitative work, clinical audit, feasibility studies, and we're at the point now that we're going to move on to some definitive trials. I thought what would be more interesting to you is to find out what we've achieved so far, and it is still ongoing. So I've taken each country and just picked out some of the highlights. So in Zimbabwe, we found that non-attendance at antenatal clinic and previous stillbirth were highly associated with recurrent stillbirth. And the impact of that was we introduced a clinic, the Tembani Clinic, which means with hope. And this is for women who've had a previous stillbirth. And in Tanzania and Zambia, we found that barriers to timely transfer, unexplained stillbirth, and communication around stillbirth were 3 really problematic areas. The impact of this is that we've introduced individual birth preparedness plans to develop underpinned by a new model, a women's health empowerment model. We're exploring the use of non-invasive investigations, and we're developing and testing a communication training intervention. Also in Tanzania, we found that partographs, which are the labour monitoring charts, if anybody doesn't know, were not completed or completed incorrectly. So we've worked with WHO in developing and testing their new labour care guide to make sure contextual relevance. In Malawi, we found that maternal observations were not being completed, and one of the areas was the fetal heart rate was not being listened to prior to caesarean section. The impact of this has been that guidelines have been implemented and practice has changed, and now there's been an increase in observations being carried out, including the fetal heart being listened to. And in Kenya and Uganda, we found that bereavement care was highly inadequate, and healthcare providers were not adequately trained or prepared in order to deliver bad news. The impact of this has been a bereavement intervention which we have developed, and it's currently being tested. And in some of the sites, they now have a bereavement counsellor who's been assigned. There's dedicated rooms and a place to rest the baby, and there's a network of peer supporters. And finally, before I pass to Tracy, just a few of the additional impacts that we've had. Stillbirth has been tabled as a priority by the Ministry of Health in Zambia, following presentations by the Community Engagement and Involvement team. There's been capacity of individuals developed. These are the researchers, some who had never done research before. We've developed a number of educational board games that you can see here for in-service training and undergraduate teaching. And we've had active input of finding the international bereavement guidelines. So I'm going to end it there, and then I'm going to hand over to Tracy, who's going to talk specifically about one of the work streams on bereavement care. Thank you.
Okay, thank you very much, Tina. It's great to be here. The Liverpool School of Tropical Medicine will be my new home from Monday, so I'm very much looking forward to starting. So as Tina said, I'm just going to talk to you about our research journey as a group. So I'm speaking on behalf of all the people who've been involved in this work stream, too many to name. So we've been doing quite a lot of work surrounding trying to improve the care and support that parents receive after their baby dies. And I think we as a group feel this is extremely important in improving care related to stillbirth, and we need to give this as much attention as any other aspect of this research. So again, I probably don't need to convince this audience, but Tina very clearly stated the importance of stillbirth and neonatal death for parents. We know that the death of a baby is amongst the most traumatic life experiences that anyone can come into contact with throughout their life. It has huge and long-lasting psychological and emotional effects on parents, which permeate more widely through society. So we know that there are poor health outcomes in terms of psychological and physical health. There's also the issues caused by stigma and abandonment within communities, and these can increase the risk of social problems like family breakdown. We've got increased health costs for governments and reduced economic productivity resulting from this terrible tragedy for parents. The good news is, though, that with appropriate care, people can move on effectively with the rest of their lives, but it's important that they do get proper care. So it's very important that parents whose baby dies receive appropriate support at that time. And we know that the hours and days immediately after the birth are particularly important and a key period for support to be initiated. And now a lot of our work globally is focused around encouraging women to give birth in facilities. So therefore, health workers have a very important role at this time when a baby dies, because those births will include some stillbirths and neonatal deaths. There has been some research done globally looking at parents' experiences of support in this period. And what we know is that even in high resource settings with good levels of resource and adequate numbers of health workers, parents' experiences are not always positive. But there's very much less known about the response of facilities and systems in low and middle income countries. So across the LAMRA network, our first challenge was to explore this issue in a little bit more detail and find out about parents and health workers' experience. So we conducted a qualitative phenomenological study. So that involved conducting some one-to-one interviews. So we interviewed 75 women, 59 male partners, and that was within a year of their stillbirth, because we wanted the data we got to represent current care. We also interviewed 53 health workers, and these experiences took place in 5 facilities in urban and rural areas of Uganda and Kenya. So what did we find? Well, not too many surprises, but some really interesting data. So the overwhelming response of the women and their partners was profound shock and distress at the loss of their baby. There were actually some positive experiences. I was listening to the previous presentation and people were saying it was important to point out when care was positive, and the parents acknowledged the efforts that some health workers were making under very difficult circumstances to give them good experiences and support, but there were lots of challenges. Parents reported feeling what they called left in the dark because of too little information after the death of their baby, and some episodes of quite insensitive and distressing communication from health workers. There were also some environmental barriers to effective care. So we've heard repeatedly that facilities lacked sufficient numbers of staff to interact with the women as much as they would have liked to. There was very little privacy and separation from women with live babies, and that was a source of distress to the parents. And some of the facilities also had some policies and processes which actually were quite unhelpful. So particular examples were restrictions on companion support. So partners would turn up once they were informed that their partner had had a stillbirth, and then weren't able to access her because it wasn't visiting hours. And there were some issues around handling of the baby's body, burials and funerals, which the parents found very distressing. Our health workers also had some quite negative experiences. They told us a lot about how little education and preparation they'd had for this part of their role, which they found particularly challenging. And there were a lack of role models to sort of give health workers some good role modelling about how things could be done well in practice. There was also a lack of institutional support for bereavement care as an important part of the health worker's role, and an increasing sense of individual blame surrounding some poor outcomes, which made health workers very fearful in looking after these parents and communicating with them. So this exploratory research has allowed us to think about developing some interventions to actually improve care. And we've very much drawn on our community engagement and our stakeholder groups that Tina mentioned in the previous part of this presentation to help us do that. So we've developed some interventions that we're now in the process of the early stages of evaluation. So we've got some feasibility work going on. So the feasibility study that we're conducting at the moment is testing a multi-component intervention which targets some of the issues that we identified in our exploratory study. So to improve care in facilities, we are developing networks of bereavement care champions. So these are health workers who work across maternity facilities in the different areas of the facility, are interested in this area of care and are raising awareness of the importance of this issue with fellow staff, and also developing some strategies for change. And it's all very led within the local facility, so they understand their context and what's possible within their facility. We were also developing telephone peer support to improve women's support after their discharge from hospital. We found in our exploratory study that women were feeling quite alone in this period. So we've trained lay peer supporters, so they're women who've had previous experience of a stillbirth or death of a baby, and they're providing support on the phone. So the design for these studies is a pre and post mixed methods study over 12 months. So we started in August 2019. We're recruiting 30 women per site to the intervention and comparing those women with a group of women who were cared for in the sites before the intervention was introduced. The study's being conducted in urban facilities in Kenya and Uganda, and the outcomes for this part of the study are very much around feasibility. So will the women agree to take part in the studies? Can we keep them till the end? How do they find the intervention? And we're looking also at the process of implementing the intervention and whether, you know, we might need to make some changes. So we conducted our training in January 2020, and that was a really brilliant experience, I think, for all of us, going to Kenya and Uganda and doing the training, meeting our champions and our peer supporters. So the training involved some elements of behaviour change theory, some work around listening and communication skills, and very importantly, for both these groups, some work around self-care and looking after themselves, dealing with this very vulnerable group of women who've got quite a lot of emotional needs. We have been faced with some issues related to COVID, like everybody else, but we're just in the process now of getting our recruitment restarted and completing this feasibility work. So unfortunately, I can't give you any results from the feasibility studies because we've not quite finished them. Hopefully we will do by Christmas. But the research, as Tina did mention before, has already started to make some impacts in our sites. So we've definitely increased awareness of parents' needs across all our sites. It's being talked about a lot more. There have been some changes to care provision. So some of the hospitals are now identifying separate areas and private spaces for these families. And staff across our Lamron network are asking for more support and education surrounding how to care for bereaved parents, which is brilliant. Working with our networks of stakeholders and our community engagement groups, we've been able to confirm a lot of commonality in our findings across the whole network in East Africa, which is great. And we've also been able to expand this work to Asia. So we had a small grant from the Global Challenges Research Fund to allow us to do some exploratory work in Pakistan, which is imminently going to start. So hopefully some of this work will be transferable across lower middle income countries. And we've got a larger scale evaluation of the intervention plan for 2021, which will be brilliant. So just by way of summary, so for our group, I think there's been a lot of learning that's gone on in our research journey so far. We've certainly discovered that history of stillbirth, poor antenatal care and labour complications increase the risk. Unexplained stillbirths are still quite an important issue, so we need to know more about this. Parents in the settings we're working in Africa go through, they describe their experiences in very similar ways to the evidence that we've got across the globe. So it doesn't seem that because stillbirths are more common in these areas, parents experience any less trauma. The care offered at facilities presently is not adequate and doesn't meet the needs of parents, and we do need to do things working with the clinicians in those facilities to improve things. And I think we're going to be busy for quite a long time because there's obviously a need for much more research and development of context-specific interventions. I think one of the biggest learnings, certainly for me, through being involved in this programme, is that you really need to do good quality exploratory work in the settings that you're going to implement interventions in order to make those interventions fit for purpose, really. So I've just got our little film, which I'm hoping, not quite sure how will that, oh, will I be able to start it like that? Yeah, so this is a film that we made
by the National Institute of Health Research to develop a research group on the prevention and management of stillbirth in sub-Saharan Africa. And this is a collaboration with the Lagina African Midwives Research Network, which is a network of midwives across 6 different countries.
So as you may be aware, there are approximately 2.6 million stillborn births annually. 98% of those are in low and middle income countries, and 60% are in sub-Saharan Africa and in Southeast Asia.
8 to 10% of our deliveries usually end up with a stillbirth.
Like in my country, it's about 22 per thousand, which is quite high.
I think I would say this is a very valuable project in the sense that it brings out the cases that we have on the ground.
So many people have, many research groups around the world have examined stillbirth to see why it happens, what's the pathology, what's the medical problems with it. Whereas this is slightly different in that this is looking from the other side. It's looking from the woman's perspective as the effect it has on them. It's looking from the midwives and the doctors working at the coalface, working in really hard situations in Africa.
What I find particularly interesting about this project is that it brings together what we know are key steps, not only in terms of problems, but solutions from both the woman's perspective, the provider's perspective, and other key stakeholders' perspective.
Health is more about just finding out the origin and the underlying causes of the stillbirth. Clearly that's important, but it's also very important that we know how stillbirths affect women, some of the underlying social reasons why they occur.
A lot of the traditions and beliefs make it a challenge for women to grieve, so we're actually looking at how can we implement interventions to make that possible in a way that's acceptable to the woman, the partners, and obviously the wider communities as well.
We need to have a special program how to handle them, how to make sure that they are going to be mentally, socially, physically fit.
We expect to have a change in the near future probably to see that the number of stillbirths reduce, and as a result of having this project going on.
So on behalf of our Global Health Group, I'd like to say thank you very much for listening. Please put any questions in the appropriate place and we'll be happy to answer them after the session. Thank you.
Thank you, Tracy. So we're just going to do a quick turnaround. There are loads of questions, but we'll keep them till the end just to manage the time. So can I have Professor Numba make his presentation with his group?
Right. Thank you very much, Charles. I would like to echo Professor Lavender's thoughts in thanking the organizers for inviting us to present the role. Could we have the first slide, please? I can't see the slide. Yeah, thank you. Inviting us to present the role of the NIHR research groups in maternal and newborn health, focusing on stillbirths and preterm births in low middle income settings. The theme respectful care is very apt and timely in global health, and I intend to present a limited perspective of current work by the NIHR research group on preterm birth prevention and management, perhaps focusing mainly on exemplifying respectful care and respectful research. Could we move to the second slide, please? Now that's the third. So I'll provide a quick overview of prime work strands and then follow that up with a few examples of our experience with women and service users and givers around respectful care and dignified care. I'll then go on to speak briefly about respectful care in relation to our physiology and pathology studies of the human placenta and vaginal swabs for purposes of understanding infection and inflammation associated preterm birth. And then I'll touch on our experiences whilst evaluating the health systems pertaining to malaria and pregnancy care in Western Nigeria. I'll mention very briefly our current work looking at the practicalities of kangaroo mother care facilities, skin to skin in the partner countries of Bangladesh and South Africa, and also from Sheffield. And we'll then present 2 short recorded videos sharing emerging data in relation to respectful care from our sexual and reproductive health work in rural Gauteng's provinces of South Africa, and also the experiences of mums of antenatal care services, particularly in relation to preterm birth, from our work in rural Bangladesh. Next slide, please. So the PRIME partnership comprised 3 countries, initially from inception on the 1st of April 2018. So the preterm birth group is slightly younger, well, by 6 to 8 months or so, I can't remember, than the stillbirth group, but has now expanded with additional funding to include new collaborator sites with new programs of work in Nigeria and the Karnataka province in India at Belagavi and Bagalkot. So that's just a snapshot of the centers and the cities where PRIME does its work currently. Next slide, please. So why are we interested in a global health research group on preterm birth? We know the statistics that 50 million babies are born preterm globally annually, of which more than 1 million die also. And even survivors are often being left with a range of disabilities, some of which can be quite profound with lifelong sequelae. And the incidence of preterm birth does vary worldwide, with a preponderance both in numbers and prevalence rates in LMIC settings, some of which have rates that exceed 15%, compared to high-income countries like the United Kingdom, with a current prevalence rate of around about 7.8%. So the PRIME Research Group seeks to explore a range of research questions to contribute to tackling preterm birth issues in LMIC settings, issues such as better ways to prevent preterm birth, better ways of identifying associated infections and subclinical infections, some of them are, which are highly prevalent in LMIC settings, indeed more so in LMIC settings than in high-income settings. To prevent or mitigate them, we prioritize training and capacity development across the partnership, and the optimal delivery if a baby is born too soon of skin-to-skin care, some of the other interventions that ensure that babies can survive with a better quality of life. We also focus quite significantly on the best way to maximize the use of limited researches in these limited resources in these settings by prioritizing the most needed research, as one of my next slides will show. Next slide, please. In terms of implementing respectful care, which is what I'm going to focus on, we do prioritize research from the perspective of the rights of women and of empowering underprivileged and vulnerable women groups. So most of our work is in rural communities and slum areas where the least privileged reside. Do forgive the basics, but we ensure that all participation in research is consensual, and recruitment of human samples is preceded by fully informed consent in all of our settings. We also try to maximize racial inclusivity by garnering and also attempt to garner and compare and contrast evidence from the different locations and contexts that could therefore enable scale-up and wider representation and implementation across a wider group of contextual areas. We do have a truly multidisciplinary team of clinicians and scientists, both laboratory scientists and social scientists, able to bring different but complementary perspectives to our engagement with and involvement of community, the public, and the patients in our research. Next slide, please. So how do we undertake the work? Part of the problem, of course, is that preterm birth is a massive problem with multifactorial etiologies. And there are so many challenges of preterm birth care in LMIC settings that what we've tried to do is to have an overarching approach to investigating preterm birth that starts out with, first of all, identifying the most important research questions, then going on to identify the evidence gaps relating to low middle income country settings by relevant and appropriate literature reviews. And then secondly, engaging stakeholders in prioritizing the research needed so that the families and women themselves, healthcare workers and policy planners have a say in what they consider to be the most relevant in their own contexts. And then we go on to conduct the research with the aim of developing practice guidelines and guidance regarding the best approaches to deliver the best care. We also look at what the most effective interventions are with a view to achieving subsequent advocacy and scale up. So in terms of where we are, we are just we're in our third year now. And from this slide, essentially what we are going to be doing, we are at the moment developing guidelines and developing tools that can then be implemented within the fourth year, which is focusing on co-development of interventions that enable for an advocacy. Next slide, please. So we have done a lot of research prioritization during extensive meetings with stakeholders in South Africa, and Bangladesh, and Nigeria subsequently, and these engagements have led to the emergence of a number of needed studies. All our stakeholders identified adolescent pregnancy as a key problem and therefore a proxy of the adverse social determinants of preterm birth in various contexts. And this was something we found both in Bangladesh as well as in South Africa, and indeed in Nigeria as well. This led to our work on adolescent sexual reproductive health in South Africa, and work on adolescent antenatal care in Bangladesh, and recently with the acquisition of additional funding, work that is about to start on adolescent nutrition in rural South India. Time limitations preclude a full narrative of the prime work strands as shown on this slide. But the next slides will touch on respectful care and respectful research in the conduct of our placental and vaginal swab studies and the implementation science studies exploring malaria and pregnancy care in Nigeria, all of which involve direct engagement with communities, women and their families, as well as policy planners and local government authorities. Next slide, please. Next slide, please. Just keep clicking because I think I've spoken about this. Yes. And the next slide. Thank you, sir. So our basic science studies to determine the viral causations and associations of preterm birth in LMIC settings is really aimed to inform maternal antenatal screening or prenatal screening or pre-pregnancy screening, and to inform interventions during antenatal care, and we undertake this work employing a range of techniques as shown on this slide, some of which are quite molecular biology based. But I really bring up this slide essentially just so we appreciate the relevance of respectful care, both in the terms of the conduct of research in the basic sciences, but also in terms of how that can be perceived by the women who we need to recruit from. Engaging with mothers, we found that engaging with mothers to recruit our samples has provided us real insight regarding the perceptions of women about research on placentas, for example. We noticed differences in context, whereby whilst placental disposal is routine in some country contexts, in some partner countries, women would prefer to take their placentas home. This does therefore pose a little challenge with regards to mounting placental pathophysiology studies in those contexts. And we've therefore had to develop approaches to tissue harvesting and processing that respectfully treat placentas so that they can be returned to parents in a state that still allows for respectful disposal at a time of their choosing. So even in basic science research and the conduct of it, it's possible to incorporate the views of women respectfully to ensure that they get the best satisfaction from engaging with some of these studies. We'll now illustrate respectful care findings from a number of our implementation and social science studies in Nigeria, Bangladesh, and South Africa. Next slide, please. So we recently concluded a qualitative and mixed methods research study investigating intermittent preventive treatment of malaria in pregnancy in southwestern Nigeria. As we will all know, malaria is the most important infective cause of preterm birth, low birth weight, stillbirth, and fetal maternal illness in endemic countries of sub-Saharan Africa. And this has remained the case for decades, despite the evidenced interventions such as intermittent preventive treatment of malaria in pregnancy, with copious recommendations for how this should be done. In this study, what we sought to do was to understand the barriers and the enablers of ITPT use in study communities and facilities in Western Nigeria. And what became very clear, particularly there are many other findings, but I'm just restricting our findings to the theme of this year's conference. What we found was a low awareness of ITPT among women and care providers, which actually surprisingly appeared to be influenced by the attitudes of antenatal care providers with regards to providing respectful care. Next slide, please. What we found was that women want care that respects and acknowledges them as well as treats them with dignity. In one of the focus group sessions with pregnant moms who attended a traditional birth attendant facility, so the setting in Nigeria is that antenatal care is provided both within the facility setting, the various facility settings and or standard hospitals, either in the government or private sector, or by traditional birth facilities, some of which are privately owned. And we conducted focus group discussions across all of those different facilities and communities. One of the pregnant women said the quote that I show on the upper half of the slide. And what that said, next, please go back to the previous slide. So, oh, what's going on? Could you please go back to the previous slide that I was talking about? Thank you, sir. So one of the women said, one can say mommy, and that's what they call the traditional birth attendant. So the mother who's pregnant says, mommy, this is what is happening to me, and they take care of you well here. That's what the mothers felt. They sit you down, that is the traditional birth attendants, and they explain things to you. In contrast, the nurses, that's in the public hospitals, are harsh. Here, they play with us, in the traditional birth facility, birth attendance facility. They play with us, they sing with us, they talk and advise us on what to do. And it's not only during clinic day that you can ask questions here at the TBA facility. In contrast, the nurses don't have time. Sometimes you go and they shout at you like you're a child. They talk carelessly all the time. You're waiting for them, the nurses, and they're playing with their phones or talking. I'm sure this is a minority rather than a majority, but that's just the perception of what the pregnant moms who attend antenatal facilities say. And when we interviewed the caregivers, there was a recurring theme with regards to respectful care. And another caregiver who was observing the interactions between the moms and the healthcare providers in the hospital said they shout at them. That one is common in most hospitals. They'll just shout, sit down somewhere, and it's not supposed to be so. They don't take time to explain things. I went with her one time, and that's this caregiver, and I saw it myself. The nurse was shouting at them. A small girl, the nurse, the women cannot ask questions or do anything. And it's their behavior that is causing the women not to come. So clearly there was a real subscription to traditional birth attendant facilities. And it was very clear that dignity and respect informed the choices by the women for where they actually have antenatal care. But actually what was really instructive was that the most TBAs were really unable to provide information on ITPT and did not have the medication to administer the WHO recommended directly observed treatment, meaning that the need for respectful care led women to facilities and providers who were nice, very nice, but did not actually have the wherewithal to provide appropriate and effective care. And one of the emerging conclusions from this study was a need to sensitize healthcare professionals regarding respectful, empathic, and dignified care to improve uptake of evidenced effective malaria in pregnancy interventions in that particular context. Next slide, please. Similarly, our current work on facility KMC in both Bangladesh and South Africa has been paused thanks to the pandemic, but it's been exploring barriers and enablers of KMC from the perspective of the women, and it is hoped to include a co-production of simple and culturally appropriate improvements based on an understanding of women's expectations and challenges. Across a range of all the other work strands which we have not discussed today, we have developed a theory of change to inform the next phase of the co-development of interventions for women, healthcare professionals, and we've already had a number of engagements with the policy planners to inform service delivery to mitigate preterm births. Next slide. So it may be slightly premature, but I just want to acknowledge the group. We don't have a photograph that has everyone there, but this is just available on our website for more information regarding the work that we do. And we'd like to acknowledge the funding from the NIHR, the Academy of Sciences that provided us a networking grant, and the GCRF funding from Research England. So we'll now move on to take two very short videos from two of my colleagues. Dr. Bronwen Gillespie is an anthropologist on Prime who will present on our work in Gauteng, South Africa. And this will be followed by Ms. Shimona Salam's video that will present our work, who's also a public health social scientist here in Sheffield, who will outline a few of our findings from rural Bangladesh. So the first video, please.
Hello, my name is Bronwen, and I would like to talk about our social science work already introduced by Professor Anamba. In South Africa, we've been focusing on adolescent experiences of contraception, pregnancy, and motherhood in disadvantaged neighborhoods near Pretoria. So we feel this topic, respectful care, is relevant for adolescents seeking sexual and reproductive health. It has important implications for maternal and neonatal health outcomes. Now, in South Africa, adolescent-friendly policy exists, including free access to contraception without parental permission, fast-track lines for adolescents, and training for health professionals, amongst others. However, implementation is very uneven and remains low in some clinics. So perceptions of adolescents, while many do use clinic services, others are dissuaded by the circulation of negative rumors. We can see one girl's account of her experience here. And both in the literature and in our fieldwork, we found that verbal abuse and lack of privacy were reported by adolescents as important limitations in their access to contraception. They felt the care they received was improved once their baby was actually born. They were then treated more as an adult. This means that many sexually active girls avoid using clinics, resulting in high numbers of unwanted pregnancies in schoolgirls, and often implies late presentation to ANC, which we already know can lead to further complications, including preterm birth. So experiences of healthcare professionals. Staff report operational challenges, mainly a lack of human resources. The nurse quoted here spoke about overburdened staff and explained how letting teens jump to the front of the queue caused conflict with pregnant women and others who'd been waiting for hours to be seen at the clinic. So health staff did actually also speak about the positive impact of training programs, especially in terms of challenging intergenerational authority and taboos on adolescent sexuality. So as suggested in the next quote here, nurses have to avoid thinking of themselves as mothers or as elders, traditionally authoritarian, and instead become allies of teens. So we could see the risk of asking nurses to promote sexual and reproductive health without a respectful approach. For example, a case where one nurse refused to remove a girl's implant and the girl ended up cutting it out herself. So lastly, towards implementation, our plans for the future, respectful care will be a central element in our plans to work with both education and health sectors and in community engagement. So why respectful care? Well, in clinics, for example, there'll be promotion of training for all clinic staff, interpersonal skills, respectful communication, and this includes the notion of adolescents as having the right to make their own decisions and being treated as such. This would be for all staff, including receptionists, who can serve as a barrier sometimes. This also would be to facilitate implementation of measures to improve privacy and specialized care, such as dedicated adolescent champions, adolescent-only rooms and lines, for all health concerns. Now, this means that adolescents wouldn't feel singled out and observed by neighbors and relatives using the clinic, and can build up trusting relationships with staff. In terms of community engagement, this would be in order to help normalize the idea of contraception for teens. This would help build support for nurses and teachers and remove some of the secrecy that discourage adolescents from seeking help. Just lastly, let me please thank the whole PRIME team, Professor Anamba, and also in South Africa, Dr. Priya Samapalai, and our funders, of course, and please urge you to get in touch. If you have further questions, I would love to discuss this further.
Thank you, Professor Anumba, and thank you, Tina. Unfortunately, we have just exceeded the time for the session, but these were two, packed, very powerful presentations, which really went on to highlight some of the key principles of implementation science and research that we've talked about all day in this conference. And very importantly, thank you for the rich information you provided about what the NHIR, funder and the research themes are about what the clinical group is, and a lot of the studies which you have talked about in various contexts. What really stood out for me was the way you were able to co-create research with the various partners on the ground, right from the planning stage, and also thinking about evaluation right from the planning stage. So I cannot emphasize enough why this is so important. Research prioritization, early engagement with stakeholders, community engagement and involvement with common threads across both presentations, and really contextualizing, what research took place, and they built in how this will be sustainable and how research will be taken up in all of these settings. Now we've run out of time, we have to stop, but all the content, the second video from Professor Numba's group is embedded in his presentation and will be available online through the web for the next year. Now, the very interesting questions all, in the app that have come through, and I'll just, plead with our presenters, the panel, to respond to each one of those ones, because for every answer you give, over 1,000 people, would benefit from those questions, and they're very relevant questions. So I just want to conclude by thanking our panel, Professor Anumba in Sheffield, Professor Tina Lavender, and Dr. Tracy Mills. So I want to say thank you to those sitting with me here, and also use this opportunity to welcome them to LSTM. Thank you. So we move now to the next session. The next session, if you want to join, there are 3 workshops, 3 different rooms. So you need to come out of this and click to join either room 1, which is about creating new health facilities, Imelda Bates and Kathy and Helen. Workshop 2, Achieving Respectful Maternity Care, Annie Potela and Salome and Tina. And workshop 3 in breakout room 3 will be Achieving Positive Birth Experiences, Sally Theobald, Indeke, and Andrew Weeks. Thank you.
The road ahead, it twists and turns, and the sun it beats down and it burns. But I keep on pushing through. And every step quicker than the last, my feet tread down this beaten path, and I keep on pushing through. 'Cause I get up and I may fall right back down, but your love lifts me back to solid ground. Yeah, I get up and I may fall right back down, but your love lifts me back to solid ground. Oh, I've come too far in this to raise my flag and call it quits. So I keep on pushing through. Oh, with every step my heart it pounds. Yes, so sure I have my doubts, but I must keep pushing through. Yeah, I get up and I may fall right back down, but your love lifts me back to solid ground. I keep on running from the things I don't understand. I'm chasing down the reasons, answers for what makes this man. Oh, the road ahead, it twists and turns, and the sun beats down and it burns. But I keep on pushing through. Yeah, I get up and I may fall right back down, but your love lifts me back to solid ground. You love you. Yeah, I get up and I may fall right back down, but your love lifts me back to solid ground.
Hello, everybody. Welcome to this session. We're going to be thinking about how we bring in implementation science to something as prosaic as a building project. So it's very nice to join you, to have escaped from the back room and find myself in front of the camera now to talk to you about this. And I'd like to welcome Imelda Bates and Dr. Kathy Burgoyne, I hope, is going to be able to join us live from Uganda as well. You've met Imelda already this morning. So I think we're going to start by seeing some presentations before we have our discussion. I'm being told we're having a bit of problem getting hold of Kathy from Uganda at the moment. Perhaps after we've seen the presentations, we'll be able to have her join us. So, Imelda, would you like to start off before we go to the presentations?
Thank you very much. It's a great pleasure for me to be contributing to this session with Kathy and Helen. We've had several previous discussions and they've got some really fascinating and interesting things to talk about. So I don't want to take up any more time at the moment, but I will be summing up with a few questions and thoughts about their activities at the end after they've given their presentations. And there's certainly some big challenges that they're going to highlight, but also some very innovative ways that they have got round those challenges. So I'm going to hand straight over to Helen to do her presentation, and then hopefully we'll have Kathy, and then I can wrap up at the end. Thank you.
Hello, my name's Helen Allard. Thank you for coming to this session. I'm going to talk to you now about implementing the construction and putting into practice the use of a maternity waiting home in a very remote rural part of southwest Uganda. The context of the area is that it's quite mountainous and the roads are not tarmac, they're made of murram, and in the rainy season in particular can become like a deeply riveted riverbed and virtually impassable at times. So to prepare, I conducted a literature review regarding the usage and the acceptability of maternity waiting homes in various low-resource countries. I went to visit another maternity waiting home in a facility in the same region of Uganda and in a similar remote setting to really meet with the women who were staying in the home and the staff who worked in the health facility and gather their opinions about having such a facility on the site where I was working. I then set about undertaking some qualitative research, interviewing women in the antenatal period to determine their preferences about staying in a maternity waiting home and to understand what would and would not make it attractive to them. There then followed a period of fundraising and construction, and finally implementation of the use of the completed building. So my question to the women who were pregnant was, is a stay in a maternity waiting home acceptable in this area? And I wanted to find out, first of all, what were women's concerns and fears regarding the birth process, and then to understand what made them choose their preferred place of confinement and the reasons that underlay those choices. I then explored women's plans for how and when they intended to travel to their chosen birth location and to understand the possible barriers that they would have to overcome in order to get to those safe places. And then moving on to evaluate the acceptability of a stay in a mother's waiting home for women in that culture. And to finally undertake a pragmatic assessment as to the sort of facilities that they would like a waiting home to provide. This is just a picture of some of the stages of construction of the waiting home.
And here is the completed building, and it's on the site of Kisizi Hospital in the North Kigezi Highlands in southwest Uganda. So you can see that it's on the site of the hospital and very close to the main maternity ward, which is behind the trees to the left of the picture. So I went on to construct an algorithm for who should be admitted to the waiting home and what were the main priorities really. And women were then categorised into risk categories. Clearly the waiting home is for well women. Women who've got antenatal illness would remain on the antenatal part of the maternity ward. But for those who are well but need to wait so that they can be in a safe place from the onset of labour, the waiting home was ideal. So the women were divided into prioritisation categories. And then looking at the implementation of the home and finding out what women thought about it. So on the whole, women were very happy with the waiting home, and they actually preferred the environment of the waiting home to that of the main maternity ward because it was spacious and clean and peaceful. We adapted the home according to the women's suggestions and requests. One example of this is that we employed a night watch lady to stay in the home and to accompany women who went into labour during the night up to the labour ward. All this was 6 years ago, and the waiting home has been very well used over the past 6 years and is being even more used in times of COVID when women have had curfews and restrictions placed on them for travelling at night. The midwives enjoy visiting the waiting home daily, even though it's an extra task for them. And anecdotally, we've had less cases arriving in obstructed labour, and the women do benefit. These are women who mostly work as subsistence farmers, and they are able to rest when they come to the waiting home prior to the onset of labour, which is something they would rarely do in their own home environments. So they are able to have a rest and gain some energy before embarking upon labour. Well, women are able to be on site prior to the onset of labour without being on the crowded main maternity ward as well. And that has had knock-on benefits for the maternity ward itself. There were challenges with implementing this programme, and in particular related to data collection. Busy staff really struggled to find the time to fill in the data collecting tools that I had constructed, and as a result the tools were often incomplete. We funded a member of staff to complete the tools, but then she moved on to another job and was not replaced. It's therefore quite difficult to get a comprehensive capture of the outcomes of women who stay in the home. The algorithm was actually rarely followed in practice, initially because plenty of beds were available in the waiting home. So it turned out that any woman who would like to go there more or less could, although perhaps this is changing a bit more as the home has increased its level of usage, in particular with COVID. There is an issue for women who go into labour and are transferred to the main maternity ward, because if the labour ward's full, they don't have a bed on the main maternity ward and they have nowhere to wait and rest whilst waiting for their place on the labour ward. We did find that some women tried to leave the main ward postnatally and go back to the waiting home, which wasn't really appropriate, just because that was their preference. And there is an issue with maintenance of the facility that needs to be supported, and we do need to find sustainable ways of providing good quality maintenance for the facility. So in conclusion, it's important to obtain evidence for the intervention before embarking on the project to make sure that it's a project that's likely to be of benefit and to avoid the pitfalls that may occur. It's key to do that to obtaining user views at an early stage and incorporating them into the building design. It's very key to get staff buy-in to the project, particularly if it will affect their workload, and one has to be prepared to be adaptable as the situation evolves. Being aware that collecting of the data can be a real issue and that this may restrict obtaining reliable outcome data if you are not physically present on site yourself. Thank you very much for listening.
Thank you. So I'm afraid we've temporarily lost our link to Uganda, to Dr. Kathy Burgoyne. We're hoping that we'll be able to link up with her again, but we're going to go straight to a video now of her very different and absolutely amazing project looking at constructing a new neonatal unit in the eastern side of Uganda.
Hi everybody. Thank you so much for inviting me here today to join in this workshop on creating new healthcare facilities. It's really exciting to be able to share with you an ongoing project that we are undertaking in the east of Uganda, and a real privilege to be able to have the opportunity to discuss it with yourselves and with Dr. Imelda Bates about how we can make this into an implementation science project. So Mbale is in the east of Uganda. It's located in the foothills of Mount Elgon, and we serve a population of around 4.5 million people. We have around 10,000 deliveries a year, and in addition, we also accept admissions from home, from healthcare facilities, and private clinics into the neonatal unit. But until 2014, we had no dedicated staff and no dedicated neonatal unit within the hospital. And as with many settings like ours, those neonates were looked after in the pediatric ward alongside older children suffering from pneumonia and diarrhea. So many of you will have attended my earlier presentation, but just in brief, in 2014, when we began this project, we started collecting data on neonatal admissions. And we were all really shocked to find that in the first month of data collection, we had 110 admissions and a 52% mortality. So following stakeholders' meetings, we implemented a 12-step neonatal care model, and we implemented it in 2 stages due to logistical and financial constraints. And what we saw that with the basic changes of hand washing, education and training of staff, and the involvement of mothers in the care of their neonates, we were able to reduce in that level 1 care the neonatal mortality down to 40%. And when we were lucky enough to open the neonatal unit and have dedicated staff, improved infection control, and some appropriate technology, we were able to reduce that neonatal mortality further still to 20%. Later on, we were able to create a high dependency unit within the neonatal unit where we had 6 cots with bubble CPAP. And primarily these bubble CPAP machines served their prematures, and we saw a huge improvement in preterm outcome. So in our retrospective analysis of the outcomes, we actually found a 44% reduction in those preterm deaths. We've now got 6 machines, and since this time we also have backup power, which means those machines never go off, and those 6 HDU cots also have continuous monitoring. So over time, our neonatal mortalities dropped from that 48% in the initial period where we had no intervention, and now has an average of 13% for the neonatal inpatient mortality. However, during that same time period, our number of admissions have gone from around 100 to 110 a month, all the way up to 240, even 250 admissions a month. So our tiny neonatal unit that we designed for 10 babies and their mothers now has up to 50 babies at any one time, together with the doctors, the nurses, and any of the other staff who are around. It really makes it a challenge with hospital-acquired infections, especially for the small ones, and also doesn't allow us to practice our Mbale mother-centered model with the continuous input from the mothers, leave alone continuous kangaroo mother care. Here you can see in the bottom right some of our mothers practicing intermittent kangaroo whilst perched on little stools next to their prematures who are on bubble CPAP. So our situation now is far from ideal. However, we believe that this clinical model can easily be replicated and have a very similar impact in settings like ours. We would also really like to create a formal training program for people to come to Mbale and learn about this clinical care pathway. But at present, we are unable to do that because we just don't have the space to provide adequate bedside teaching and practical training. So we partnered with HKS, an international architectural firm who have extensive experience in designing hospitals in various settings. And we involved very many of the stakeholders, interviews with the mothers, the families, the nursing staff, the doctors, as well as local district officials. And we came up with some key aims of what this new neonatal centre of excellence should be. We wanted to support our proven clinical model of neonatal care, but we also wanted it to be affordable so that this could be replicated in other similar settings for minimal cost. We wanted it to be sustainable, particularly in terms of electricity and water, and we wanted to be able to reduce those hospital-acquired infections for the babies within the unit. We wanted to maintain the temperature, but our air circulation is horrific, and we really wanted to improve that with the hope that that would also reduce hospital-acquired infections. And key to the success of our model has been the Mbali mother-centered model, where the mothers are there all the time to monitor their children, breastfeed, provide express breast milk, measure their temperatures. So we really needed to create space for the mothers to come back into the ward. And we also wanted to improve the quality of their life. And finally, as I previously mentioned, we wanted to create space so that our Centre of Excellence could facilitate training for other healthcare workers from other regions across Uganda. So this map shows you the location of Mbali Regional Referral Hospital in that pale green area. And at the back here, you can see the current site of the neonatal unit, right adjacent to the postnatal ward and in really close proximity to labour ward and to labour ward theatres. The dark green area is our plot of land where we will build the neonatal unit. So not only does it maintain that close proximity to those areas, but it also lies, as you can see in the top right photo, right next to the road to facilitate those infants coming from other facilities or other clinics directly into the neonatal unit. Each wing of the ward has plenty of space to allow space between the mothers and the babies, but also allow the mothers to sleep within the ward to provide that Mbali mother-centered model. HCare is really focused on the environmental elements of the design, and this slide here shows you some of those key features. You can see here the sloping roof to facilitate rainwater harvesting. You can also see the large surface area of the roof where we can place solar panels that help generate energy for the neonatal unit. The central area of the roof is elevated to help with the air circulation within the ward, and also a lot of windows to make it light and airy for those people who are working within the neonatal unit. The shape of the neonatal unit may look unusual, but it is built like that on purpose. In our setting, it's very common to have maybe only one or two staff to cover the entire ward. So if you look on that left picture, you can see the blue and the red spots on that slide, and those two nurses together have got 100% visibility of all 52 cots within the neonatal unit. There are many functions that we considered in the design of the neonatal unit, but just to take you through a key one here, and that's the entrance of the neonatal unit, which is one entrance only, so that we can really focus on infection control at entry. There's an area for the mothers to lock away their belongings so that they don't need to bring them into the neonatal unit. And after that, they pass through an area specifically for removing their outside garments and putting on their ward gown. And lastly, they pass through a hand washing area. And all of these areas face directly onto the nurse's station so that we can keep a close eye on those people who are entering into the neonatal unit. As one might expect, many of our mothers stay on the neonatal unit for a very long period of time, especially those who have prematures, whilst they wait for their babies to grow and they learn how to look after those babies at home. So what we've designed here is an outside courtyard area for the mothers and for their families, hopefully to allow them to relax a little and to improve their mental well-being. And as you saw in the earlier slide, we have 3 separate wings to the ward, and this will allow us to segregate the neonates slightly. So those prematures who don't necessarily have infections but are at high risk of acquiring infections can be kept separate from those neonates who are coming to us specifically with infections. It will also allow us to focus care like oxygen therapy to certain areas of the ward, and we can keep the high dependency unit entirely separate from the rest of the ward. So these are 2 images of what we hope the neonatal unit will look like in a year or 2 from now. And I look forward to discussing with you all now how we can make this into an implementation science project. Thank you.
Imelda, do you want to kick off? Can't hear you.
I don't know why you can't hear me.
Oh, we can now.
I think there's a very big delay actually between you and me. So thank you very much. And Kathy, are you with us in real life now?
Yes, thank you, Imelda.
Okay, excellent. Thank you. So thank you both of you for amazing presentations about all the work that you've been doing. This is clearly a huge investment of your time and energy and making an enormous clinical difference to people on the ground for the maternity home and for the neonatal unit. So I picked out a few commonalities and I just wanted to ask you about them. And then I thought we could focus a little bit on some of the key implementation research questions that might have occurred to you or occurred to me as I was listening to the presentation. So I just wanted first of all to ask both of you about the challenges and what you might have done differently, given that you're both trying to implement on the ground real frontline clinical services and you're absolutely involved in delivering those, and yet you're also trying to run high quality implementation research alongside that. And I can imagine that that is like 2 or 3 full-time jobs for both of you. And how did you actually manage that? And with hindsight, would you have done anything different? So maybe we could just ask Helen first.
So our waiting home, we built it in 2014, and the research I did was part of my MSc in global health at the time. So I think, I mean, in hindsight, it would have been better to have done the research a little bit earlier on in the process, but I don't think in the end it made a difference because all the useful things that we learnt from the women, we were still able to implement just as the home opened. Things that they suggested to us and things that we had to adapt as we went along. So, for example, we realised that because there weren't staff on the waiting home all the time, the midwives just visited once a day, but at night the women were a bit scared on their own. So then we employed a night watch lady to stay with them and sort of fend away any visitors of the opposite gender who might like to come in at 2 o'clock in the morning. And also to accompany the women up to the labour ward when they went into labour. So, and it's been quite iterative as we've gone along, really, to sort of see what the women needed and wanted and where feasible to try and implement those changes. So I'm not sure that in terms of the sort of planning and the building of the building, we would have done things differently in hindsight. I think my main challenge was much more to do with the data gathering to look at the outcomes for those women. And that remains a challenge because I'm not there most of the time and the staff who are there are incredibly busy and it's very difficult for them to take time out to collect all that data.
Thank you. Kathy, do you have something to add to that?
Thanks, Imelda. So I think when we opened the first neonatal unit, we really did struggle with our data. I mean, no data was being collected at all on the numbers or the outcomes, and we really did try to focus on that, but it was all very paper-based. And thankfully, we've worked with another group of people, and we've been able to put our key data set electronically. So that is still not complete, but it's much better than the paper-based data set. So that's really helped us improve our data collection prior to the creation of our new neonatal unit. And as I mentioned, we've taken a lot of time to do stakeholder meetings, particularly with the mothers and the families when the HKS architects visited us here in Uganda. And I'm really glad we've got that. We've got the experience. We even have GoPro footage over 24 hours to show how crazy it is in the neonatal unit. So we've got kind of that middle assessment period, and hopefully we'll have the end assessment period when we've created the brand new neonatal unit and be able to look at the quality of life of the mothers and the staff, and also probably undertake another GoPro and see what the flow of people is like and the movement through the infection control procedures. But I wish we'd done a lot more of that right at the beginning. We really focused on the stakeholders being the nurses, the doctors, the district health officials. I think the mothers didn't know what was missing at that point. There wasn't a knowledge of neonatal care. To be honest with everyone, there wasn't a knowledge of neonatal care. And so I think perhaps it would have been hard for them to assess that. But I think qualitative interviews right at the beginning, we didn't do. And I think that would have been really beneficial to have that on top of the quantitative work that we did.
Thank you. It's really interesting because I think both of you started off knowing that you needed very good baseline data and that you needed to talk to lots of stakeholders, which is a really good start because many of these sort of facility building projects, you often find that people have done a lot of the work before they start thinking about doing the research and collecting the data, and then it's really difficult to show the impacts. So one of the other things that really struck me was that both of you had a really well-defined problem that you were addressing. You need to get your pregnant women very close to the labour ward, but not blocking up the labour ward. So that was the idea of a maternity home. And then the neonatal unit, trying to address the high rates of mortality. So there were clearly very important clinical issues that you both had identified and were trying to find a solution to. So I can see some very much commonalities there. And you were both immersed in the environment. And you talk to people about what they needed. So I think this is another really good example of things that were talked about this morning at this conference around early planning, early engagement, and the flexibility that Kathy just mentioned of listening to your users and understanding what they want and then being very flexible and able to adapt as you go along, which Helen also pointed out. They'd, adapted things quite a lot as you go along. So, I thought maybe what I should do is just throw out a few ideas about some of the implementation research questions that occurred to me for both of your studies. And perhaps you might be able to just give me an idea of whether you think they might be practical or not practical and how they might be implemented if you're interested in them. So I've sort of divided them up into clinical issues and then more social science research, because both of you have touched on clinical issues, women in labour, neonatal infections, for example, but also you've talked a lot about the user's perceptions and design of the facilities. So those are much more amenable to social science type research. So first of all, Helen, I wondered whether you had thought about trying to actually measure whether the complications in these women might have reduced because of the waiting home.
Yes, indeed. I mean, I think we had quite a lot of anecdotal comments from the midwives about that, and in particular relating to a reduction in number of cases of obstructed labour who came to the facility very late, perhaps after a long struggle to get there. And I think that's particularly relevant now with COVID, when there have been curfews at night and it's been more difficult than ever for women to get to the health facility during the night. And I think that's quite a fear that the women have had. And so we've seen an uptake in usage of the waiting home because of COVID, because they are voting with their feet and coming earlier. But I think certainly looking at outcomes like the number of cases of obstructed labour, the proportion of cases of obstructed labour or of stillbirth that are rising. And I think, for me, the sort of idea first came to me really because at a time when I was working clinically in the unit, I had a woman come in with a ruptured uterus. And she lost her baby and she lost her uterus. Fortunately, she lived. But she lost her child and her chance to have another one because she had no phone with a charge on it. There was no electricity in her village and nobody with a vehicle. And she was 10 kilometres away from us. And that was what kind of drove the idea of having the waiting home in the first place. So it's key to reducing clinical outcomes like that. So I think absolutely essential that we do track the outcomes of these women and make sure that they are for the good, that we are achieving what we set out to achieve.
Yeah, Thank you. Maybe what I'll do is just bounce between the two of you. So maybe Kathy, I know that one of the questions that must occur to everybody is, does the very innovative design of this unit actually result in reduced infection rates amongst the neonates and also general mortality? And have you got an ongoing data collection that might enable you to show that? And how easy is it to do alongside a sort of busy day job?
Thanks, Amanda. So we do have our outcome data, and I think that we've probably got that as good as we can in a setting like ours. There's still the odd patient that, as we call them, runs away, and you don't really know whether they died before they ran away or they didn't. So, you know, we're as good as we can get in a setting like ours. And like I mentioned, it's all electronic now. I think the key for us now here in Mbali is to think about those additional outcomes that we're interested in. And one of them you mentioned is hospital-acquired infections, which for us is a huge challenge. We only have 2 sinks in the ward. We don't always have an ongoing water supply. And I probably spend, it feels like 90% of my time on the ward telling people to wash their hands as they come in. So, and babies, you know, so close now because of the increased admissions and the reduced mortality. So I know that hospital-acquired infections are a huge problem. But at the moment, we don't have a data collection system for that. It would require us to go back to the medical records of each of the patients and see whether we could, definition, find out how many hospital-acquired infections we have in the current period and what we will have in the new unit. But I think it's something that we as a group need to think very seriously about, at least for the next 1 to 2 years, whilst we're constructing the new neonatal unit, collecting the data in the pre-intervention period. And I really hope that it does have an impact. It might be that we need to go further and look at the microbiology of it. What we do see now is that a lot of our babies who get sepsis unfortunately have multi-drug resistant bacteria, E. coli, Klebsiella, which clearly most likely came from a hospital-based setting, whether it came from the labour ward or from postnatal ward before they came to us, or maybe even from the neonatal unit itself. So I think there'll be many levels that we can study that at.
Thank you. Yeah, lots of opportunity, but also quite a lot of resources needed to be able to collect for both of you the really high quality type of data that you need. And that it does require quite a lot of money. It requires staff. It requires, you know, oversight and supervision to make sure the quality of the data is very good. And I think it would be really hard to try and do that alongside everything else that you're doing. I can see that although you want to show it and you know you're improving things, actually demonstrating that with hard evidence takes quite a lot of resources. I just wanted to pick up on the issue that both of you were talking about, which is the issue of how busy staff can also be expected to provide high quality data. So I know, Helen, you raised this initially. So did you have any thoughts about that? Is this a really common problem when you're working in busy clinical health system situations, that people just don't have the time to give you the data? And had you had any bright ideas that might be useful to everybody listening?
I don't think it's a quick fix. I will say that the hospital has been very innovative in the last year or two, introducing an electronic system of patient information. And I'm hoping that going forward, we'll be able to adapt that and add some specific data about the waiting home to that, so that we'll be able to capture a bit more about the outcomes of those women electronically. But of course, it still requires somebody to enter it into the electronic system. So that can take a little bit of extra time sometimes, particularly when people are learning how to use those systems. Lots of investment in training staff in the use of an electronic system, I think, is key. And yes, I guess I think if we had been able to employ somebody else as our data collecting clerk who was paid to do that, it might have helped us. I had somebody at the beginning. She went off to actually become a student midwife, which was great for her, but there wasn't anybody else really available to replace her at the time. But I think I agree with Kathy in a way that having an electronic system is perhaps the way forward. Once everybody gets used to it, it might make things a bit better.
Kathy, did you want to add anything to the issue about trying to collect high quality data in a busy clinical environment?
Yeah, I could. I mean, when we started with paper logbooks, and we put our own titles, and we kind of guessed what we wanted to collect. And then actually the Ministry of Health, they have a minimum data set that they want to be collected, although there's no fixed logbook for neonatal units in Uganda at present, although we hope that that will change. So we developed our logbook with the Ministry of Health titles so that we got that minimum data set. And we had various conversations, both locally and internationally, and about increasing that data set. But as you've alluded to, everyone is so hard pushed for time. 1 nurse, 2 nurses, 50 babies. We felt it was better to restrict that data set to the basic things that we really wanted to know, age at admission, the weight at admission, outcome, where did they come from, that kind of thing. Nothing too complicated, so that people didn't get scared off and didn't enter it. And then we've worked actually with something called DHIS2, which many of you may have come across. And so we've based our data collection tool on DHIS2, which makes it compatible with a lot of the other data systems that are already up and running in Uganda and other countries, which it doesn't help us at the moment because we haven't got our data uploaded onto the internet, but we hope that in the future that it will be able to allow us to spread it at least into Kampala, into the Ministry of Health, and wider across Uganda. And then I suppose with our data set, you can't get an inpatient number for your patient until you filled in your data set. So if you want to do anything for your patient, a blood test, an X-ray, you need that IP number. And so actually not all of the data variables are compulsory, but there are ones with little red stars that you have to fill before you can get that IP number. And we did training with the nurses, and even those that were not so technically able at the beginning, they really preferred it to the paper logbook, where pages fell out and perhaps weren't completely aligned, and it just got a little bit stressful. Someone made a mistake and then everyone made a mistake afterwards. We get automatic IP numbers, which helps. And then, yeah, I think that's probably the key things that have helped us to make it successful. And the laptop is right there in the middle of the ward, so you don't have to go any further away to be able to enter the data. So yeah, I think those are the key things.
That's really helpful. And I think, having seen lots of implementation research projects, I think those are things that they don't sound like big things, but they make such a difference to being able to collect the data at the time. So thank you. I've just got a couple of other common things that I picked up across both the projects. So the first one was about, have you got any ideas or reflections on engaging your users? So engaging the pregnant women, engaging the mothers of the neonates. Could you have done this better? Would you have done it differently? How do you think you could make it effective? Because engaging stakeholders right from the beginning is something that's so critical to all implementation research. And then I was just going to ask you one last question about sustainability, and I know that's quite difficult, so I'm putting it out there so you can have a little think about it before I ask you. So maybe, Helen, maybe you could just talk a little bit about engaging all your users and hints and tips or suggestions, reflections, lessons, anything like that that might be useful for everyone.
Thank you. So the hospital have a number of satellite antenatal clinics, some of which take quite a while to drive to, down some of those awful roads that you could see in my pictures. And so those are women who really would struggle to get to the hospital in a hurry. So it was very good to engage with them and spend time really. And I probably spent about an hour each talking to each woman to find out really their thoughts and wishes about a waiting home, and how easy it would be for them to use the facility. And I think this varies in different cultures. One of the worries is that women won't want to come, for example, because they might be leaving their other children at home. In our culture, that didn't seem to be an issue at all for almost all the women, because there was always a grandmother or an auntie or somebody else at home who, you know, on the compound, who would very happily look after the older children of that woman. So it happens occasionally, but very rarely an issue. But I think that's something to watch out for, really, that there are ways that the women are able to get to the home. And another issue that came up affecting what women thought about it was concerns about would they have to stay there alone. And initially we thought we didn't want the waiting home to be cluttered, and we thought these are not sick women, they could probably be all right to look after themselves there, but they didn't want that. They wanted to have an attendant, a member of their family with them. So then, having talked to a lot of the women, we decided that we would change it so that they could have another female relative staying with them in the home, say like their mum or their sister or somebody like that. So I think sort of responding to those wishes, and that wasn't difficult to do, and being very much upfront about, well, what would you like the home to have? And their requests were very simple. They wanted a bed to lie on and some sheets and blankets. They wanted some water to wash with, somewhere to do their cooking. So I think most of the things that we had thought they would want were actually what they wanted, just the basics of life. We're very lucky that we have a waterfall on the site, so we have hydroelectricity, so we don't need to have any solar panels on the roof because we have a hydro project that has a good supply of electricity. So we're able to heat the water, and for a lot of these women, they had not been able to have hot water before, so they were very happy to do that. So I think having that time to really get to grips with what the women most wanted from the facility was key to the acceptability of it to them.
Thank you. Excellent. Kathy, your experiences of engaging your users.
Yeah, thanks, Amanda. I think, you know, like I've got kind of two different time points now. I've got the time point when we had nothing at all, and the time point now where we're trying to improve a service. And I think even if I go back now 6 years ago and think about how I'm going to involve the stakeholders when there's no service there at all, it is actually really challenging because people don't know what they don't know, and they don't know what they're missing out on. And so, you know, we did have medical workers, but even the medical workers hadn't been to a neonatal unit before. So it was very hard for people to imagine what they might want or what they might need when they haven't even had a little bit of an experience. As we started, we were able to involve the immediate mothers that were admitted into the ward, you know, and get their feedback verbally on a one-to-one basis. And the other avenue that we used, we went onto the local TV station, which was kind of funny, but, you know, myself and one of the local nurses or midwives would go on our 9 o'clock Tuesday evening slot, and we'd talk about one key element, maybe, you know, cord care or kangaroo mother care, or how we're going to be feeding babies with a nasogastric tube. And I think that really helped to sensitize the community, at least locally within our region, about what was going on and that this service was there. It's much easier now that the service has been there for 6 years, as we move on to the new neonatal unit, to get back to the older mothers who've previously had babies in the neonatal unit, be the ones who survived or didn't. They both have different ways to, you know, feed back to us and input, and lots of them do come back and visit to us. So if we move forward, we will be able to undertake the qualitative interviews, meet with those mothers and get feedback. And I think it's really important, and people have mentioned it throughout the day, but to really involve the people at the top. And somebody mentioned earlier, they change over so quickly. You know, all of the district health officials, you know, they've changed 2 or 3 times since I've lived here in Eastern Uganda. So you really have to keep on top of that. So you've got the support from above, and engaged the upper stakeholders as well as the users as well.
Yeah, thank you. A system-wide approach, definitely. Thank you. So I know we've only got a couple of minutes left, but I thought maybe these are quite long-standing projects, so you must both have some idea of things that might have helped promote sustainability. So I just wondered if in a couple of sentences from each of you, whether you could give us some idea of what you think is critical to keeping these initiatives sustained. So Helen first.
In terms of sustaining the quality of the home, I think, you know, you need somebody to be accountable and to take responsibility for going in there regularly, making sure the taps are working, making sure the mosquito nets have not torn or come down, making sure the curtains are there. And so just the basic nitty-gritty to maintain the quality of the place. And we usually ask the mothers to be in charge of cleaning the home themselves, and they're very good at that. They take a pride in doing that. So the day-to-day cleanliness sustainability is run by the mothers. I'm the chair of trustees of the NGO that supports the hospital, so we kind of have to raise the money to pay for things to keep the building in good condition. And I guess you could say that's not sustainable, but I would argue that no hospitals, even in this country, are sustainable without charitable funds. So I don't know how we can expect somewhere in a small part of rural Uganda to be any different.
Thank you. Thanks, Helen. Yeah. Kathy, sustainability.
I think that's the biggest challenge with anything that any of us are doing. And if anyone has a good answer for this, I would love to hear it. We all envisage our projects living on forever and ever, but I mean, as Helen's alluded to, they do need a continuous input at some level so that they don't deteriorate. I suppose from my experience here in Uganda, our project is nested inside the Ministry of Health, a government hospital. So some of the staff come from our NGO, but the majority of the staff do actually come from the hospital. We fundraise for the equipment and the hospital provides the infrastructure. And actually we were very clear at the beginning of the first neonatal unit that we weren't going to do anything unless we had a buy-in from the hospital. We didn't want to come in and put a neonatal unit and then leave. So really we had very many meetings with hospital administration and Ministry of Health to make sure that it was a joint partnership and it wasn't just owned by one group of people, that everybody had an invested interest in that. And then I suppose what's been really key is training. So when I first came here 6 years ago, it was little me doing all the training, but I don't do any of the training anymore. And, you know, all the training courses are run by local trainers, and I think that's really key. And since I've been here, I've been on maternity leave twice, and nothing dreadful, touch wood, has happened. And you know, things would trickle and go downhill, I think, over a long period of time. So you do, like Helen says, need to keep that input at some level, but every project will be different.
Thank you. Excellent. And thrown up some real challenges, but also some amazing examples of how you have worked hard to embed these within local systems. So I know that we've just come to the end of the session, so I thought I would just pick up 3 take-home messages that I think came from both of you. So one is very practical about the data collection and things around actually having a dedicated person, a research assistant or a clerk or someone who can be responsible for collecting good quality data. Working within existing systems and using the stakeholders top to bottom of the system to try and embed and keep it going. And then being extremely flexible and responsive to your users and everyone else who's involved, but also really pushing hard for local ownership, local empowerment, and for the local teams to really take over so that you can step back. And ideally, at the end of the day, these should just be running themselves with a very light hand on the tiller, probably. So I think we should probably stop there because I think our time is up. But thank you both very much for these really amazing case studies of implementation, research, and dedicated clinical practice. So we should hold it up as an example, both of them, to everyone. So thank you both very much. And Helen, I don't know if you have something to wrap up or not.
Oh, I just want to thank and acknowledge the staff who work very hard day after day in trying circumstances in Kisizi Hospital in southwest Uganda. I'm sure some of them might be watching us, so thank you all so much.
And Kathy?
Yeah, I think the same. I mean, none of this is done by one person on their own. It's a team effort, and actually I've learned so much since I've been here, and everyone can teach everybody else something, and you can't do it alone.
Thank you. Wonderful message to stop on from both of you. Thank you so much for a really fascinating session. Thank you.
Thank you.
Thank you.
The road ahead, it twists and turns, and the sun beats down and it burns. But I keep on pushing through. And every step quicker than the last, my feet tread down this beaten path, and I keep on pushing through. 'Cause I get up and I may fall right back down, but your love lifts me back to solid ground. Yeah, I get up and I may fall right back down, but your love lifts me back to solid ground. Oh, I've come too far in this to raise my flag and call it quits. So I keep on.
Hello, everyone. So congratulations for hanging in. It's the end of the day. It's been an exciting day. We just have, 4 unique presentations to run through now. This is using the Pechacucha style. So these are research studies that will be presented just using pictures and some narrative. And the exciting thing about this this part of the day is that you have the opportunity to pool to vote which of these 4 is the best. Now, you just wait until we have the final presentation come through, and then, we will tell you when to start voting. And we have a prize for the best presentation. So I'll be running this session together with Helen, my colleague, Dr. Helen Nabuera, and we will listen to each presentation, and then we will discuss some key points from the presentation as it links to, the process of implementation science, implementation research. And then you will have the opportunity to vote for, the best at the end of all 4 presentations. Okay? So can we please have the first Pechacucha style presentation? Thank you.
Hi everybody, my name is Valentina and I work at the University of Manchester. I present a qualitative study on the impact of communication on women's experience of grief following stillbirth in Malawi, Tanzania and Zambia. So communication is an important component of care, and when parents experience a traumatic event such as stillbirth, the communication of that need to be done in a respectful and sensitive way by the provider. From the literature, we know that parents appreciate that the information are clear, honest and timely, especially about the death of their baby. They want to know the cause of death to prevent another stillbirth, and they will have a very long-term memory about the language, the gesture, and the behavior of the providers. On the other hand, when the messages are poor, there is lack of confidence of the providers, or there is lack of reassuring words and empathy, this creates frustration and anxiety and make parents doubt the clinical explanation of death.
Yes, so I think we had a problem there with the first presentation. Are we going to try and play it again, or do we move to the next one? Move on. Okay, thank you.
Sub-Saharan Africa is undergoing a massive demographic and nutritional transition associated with rapid urbanisation and adoption of what we traditionally call Western or affluent lifestyles. But these terms are outdated and misleading. Simple sugars and refined carbohydrates, they're quickly becoming cheap and convenient ways to feed a family, not only in the West, but the bulging cities of Sub-Saharan Africa too. Non-communicable conditions such as diabetes and hypertension are therefore becoming pressing public health priorities in the region. The impact of overt forms of diabetes and hypertension on poor pregnancy outcomes are well documented. In addition, recent evidence suggests that moderate elevations in blood glucose and blood pressure also increase the risk of adverse outcomes. However, the majority of these studies have been conducted in Caucasian populations and in the high-income setting. Not only are there possible differences in the phenotypes of these conditions in different populations, what kind of management can be offered clearly depends on the resources that are available. Caution must be taken when translating the evidence between such vastly different settings. The aim of this study, therefore, was to determine the contribution of moderate elevations in blood glucose and blood pressure to poor pregnancy outcomes in Ugandan women. The study was undertaken in 5 major hospitals in urban and peri-urban central Uganda and was a nested study within a wider study to understand the determinants of hypoglycemia in pregnancy there. Women in the antenatal clinic were approached between 24 and 28 weeks and invited to take part. Exclusion criteria included major comorbidities such as heart failure or kidney disease, or a prior diagnosis of diabetes mellitus, or an established diagnosis of preeclampsia in that pregnancy. Women were given information to take away and then returned for full enrolment. They filled a study questionnaire detailing demographics and obstetric history. Anthropometrics such as height and weight were measured. 3 blood pressure readings were taken. We were using an automated Omron machine, embarrassingly not the cradle device. Women had been asked to fast overnight. They did a full 75-gram oral glucose tolerance test, though this was a nested study, and we were only really interested in the fasting venous blood glucose, as this is arguably the most feasible way of screening for hypoglycemia in pregnancy in this setting. All samples were immediately centrifuged, refrigerated, and subsequently analysed at the central MRC laboratories within 24 hours. Women with overt diabetes or hypertension were excluded from our analysis. These were defined as a fasting venous blood glucose of more than 7.1, that's the international cutoff for overt diabetes in pregnancy, and a mean arterial pressure of more than 107 millimetres of mercury, so that's equivalent of 140/90. A moderate elevation in blood glucose was therefore defined as a fasting sugar between 5.1 and 7.1, and a moderate elevation in blood pressure defined as a mean arterial pressure between 90 and 107. The primary outcomes of interest were large birth weight babies, that is above the 90th centile, and perinatal death. We used multiple logistic regression analysis to determine the contribution of our variables of interest, our moderate elevations, as well as other confounding variables such as body mass index, age, HIV status, health facility, to name but a few. Overall, almost 5,000 women were approached, of whom just under 4,000 enrolled. Of these, around 3,000 were included in the analysis, with the others missing key laboratory or outcome data. 66 women were excluded because they had either established hypertension or a blood glucose in the overt diabetes range. So what did we find? Of our 2 variables of interest, moderate elevations in blood pressure, but not blood glucose, were associated with an increased odds of perinatal death. So women with a mean arterial pressure of more than 90, but less than 107, equivalent to 140/80, were twice as likely to lose their baby than other mothers. Neither of our 2 variables were significantly associated with large birth weight babies. There was a positive trend between blood glucose and large birth weight, with an adjusted odds ratio of 1.33, but with a confidence interval of 0.94 to 1.90. One could argue, of course, that this is due to small study effect size. But what's really interesting is that the independent contribution of obesity clearly outweighs that of moderate elevations in blood glucose. So women with a mid-trimester BMI of more than 30 had an adjusted odds ratio of 2.30, confidence interval 1.75 to 3.02. A notable and encouraging finding is that a self-report of previous macrosomia also independently predicted large birth weight with an adjusted odds ratio of 2.47. So what does all this mean, and what are the clinical implications? Well, measuring blood sugar is an expensive business, and managing moderate hypoglycemia is resource intensive. This photograph shows the typical number of glucose measurements a woman may be able to afford throughout the entirety of her pregnancy. On top of this, we already know that managing mild forms of GDM doesn't really reduce many of the important pregnancy outcomes of interest anyway, And that's even with expensive measures such as capillary blood glucose measuring 4 times a day and insulin therapy. In an environment where resources are so limited, there would have to be a very good reason to focus on blood sugar. And while this clearly isn't a cost-benefit analysis, our results suggest other factors are likely more important. Encouragingly, the identification of obesity and previous history of macrosomia are as good as free, and are clearly associated with poor pregnancy outcomes. Focusing on these, perhaps triaging women into higher risk antenatal care streams and working on interventions that mitigate risk, may offer more value for money than focus on blood sugar analysis, for example. As for blood pressure, our findings highlight the importance of recognising risk with blood pressure readings that are below the international standard set to escalate care, that's 140/90. Unfortunately, many settings still struggle with identifying even established hypertensive disorders in pregnancy, let alone more moderate elevations. So, to reiterate the headlines, moderate elevations in blood pressure are associated with perinatal death, and large birth weight seems more closely associated with obesity than moderate elevations in blood sugar. Thanks for listening, and a big thank you to all my colleagues in Uganda too.
Yes, thank you, Jack. That was an excellent presentation. Helen, how did you find that presentation? How does it link to, the overall theme of implementation science we've been hearing about today?
I think today we focused a lot on interventions, but what Jack's presentation is doing is taking us back to actually identifying what the problem is, and then the next steps obviously will be what we've been discussing a lot today, how you then develop interventions. And I think that is key in terms of identifying what's the priority in this setting, what is the problem, to then going on to develop the intervention. And I guess we focus a lot on core development of the intervention, so both the researcher, the stakeholders in the country who should involve the patients as well.
Yes, excellent. I mean, I really like one of the things he said in the beginning where he says, it will be difficult for us to transpose evidence from a different setting into a local setting. Yeah. And so whereas we know exactly what works elsewhere, we needed to look for the local evidence. Probably because of the length of the presentation allowed, I would have liked to see him emphasize how, the local stakeholders were involved in designing the research and, the link to the uptake of the research just for sustainability, as we have said. But I think it was a very important, research about a local problem, and a recognition that, there is not a universal solution, that context is quite important, as came out from Sally's presentation.
That's right.
Okay, excellent. So I think we'll move swiftly to the next presentation, and we have a brief chat again after that presentation. Thank you.
Hi, my name is Georgina Page and I work with the Evidence to Action team at Marie Stopes International. MSI is a global organisation. We work in 37 countries providing sexual and reproductive health services. I'm going to walk you through our experience of using human-centred design to develop an intervention to improve access to family planning for adolescents in the Sahel. For MSI, our clients are at the heart of everything that we do. Ensuring we are delivering respectful and non-judgmental services to those that need us most is core to our mission. We work in 4 countries in the Sahel: Burkina Faso, Mali, Niger, and Senegal. And one of the biggest challenges remaining in this region is how to expand access to family planning for adolescents under the age of 20. Our research indicates that lower use among this group is driven by misunderstandings of side effects and concerns about future fertility. Newly married adolescents are under intense social pressure to prove their fertility, and this makes them and those influencing their decisions, like husbands and older female family members, really suspicious of anything that might jeopardize this. So, in 2017, MSI launched a project with the support of the William and Flora Hewlett Foundation and design agency IDEO.org to use human-centered design to develop an intervention focused on improving access to family planning for rural Burkina Faso adolescent mothers in the areas where we have mobile outreach service delivery teams. While existing MSI and secondary research provides some insights into the experiences of these young women, adolescents in the Sahel context often lack a voice when it comes to the issues that most affect them. We chose to use human-centered design to make sure that whatever solutions we came up with were developed with these young women central to the process. Immersive qualitative design research at the beginning of the project in rural Burkina Faso allowed us to understand not just adolescent women's experiences of attitudes towards family planning, but also how this relates to their lives more generally, in terms of their future aspirations, family decision-making, and other influences on their lives. In synthesizing the findings from the design research, we were able to build a picture of the different types of adolescent women we were designing for. With a better idea of their engagement with and knowledge of family planning, as well as their hopes and fears for the future, we were able to start to identify opportunity areas where we might be able to introduce interventions to help expand their access to family planning services. Once we had some of these rough ideas, we started to prototype them. A key principle of human-centered design is to iterate and test your ideas throughout the process. This is a great way to involve those you are designing for in developing the tools and solutions, and to learn quickly from them what works and what changes that you might need to make. As soon as we had some initial prototypes, we took these back to rural Burkina Faso to test them. We took 5 different prototypes back to the field and created several more while we were there, directly building on what people were telling us as they tested them with us. Feedback from these tests pointed to 2 prototypes which were likely worth developing further. One of the most successful prototypes was a community board game. This proved effective in tests at opening up positive discussions about contraception among the wider community and engaging men in these conversations. Young women told us during the design research that community resistance to family planning and a lack of male engagement were major barriers to them being able to take up a service. To complement increased acceptance at the community level, our second successful prototype sought to encourage couples to discuss family planning in the context of the future of their family. And we developed a set of visual cards to be used during a facilitated conversation to help enable this. Once we had identified the prototypes that appeared to best meet the needs of our users, it was time to test them at small scale in a much more real-life setting. So 4 of our fantastic mobilizers in the Burkina teams started to use the game and the conversation cards in their day-to-day mobilization activities, and they did this for 3 months to help us really understand how they were working and what changes we might need to make. After a few minor iterations, including some waterproofing to deal with the rainy season, we had our pilot version of La Famille Ideale. This consists the community board game, working and supporting increased overall acceptance of family planning use, and the facilitated couples conversations to help enable shared decision making. These are both coordinated around the delivery of quality SRH services by our MSI Burkina teams. A rapid evaluation at the end of the pilot phase indicated that exploring family planning in the context of overall family aspirations like education and financial security, including a myth-busting quiz and lighthearted role plays, meant that the board game especially was able to create a positive community dialogue about contraception not achieved in other types of mobilization activities. This success was reflected by improvements in the number of adolescents accessing services with the Burkina teams who were piloting the tools. There were improvements over time among these teams and compared to teams that were not using the tools, indicating a positive impact on our overall project objective. The evaluation also highlighted important recommendations for how to use HCD at MSI. This is colleagues from our Niger program playing the La Famille Ideale board game. And ensuring engagement like this among those who will be involved in supporting and using the intervention is critical to a successful rollout. They are also your users and you need to involve them throughout the process. A secondary objective of the project was to explore how to adapt La Famille Ideale for use elsewhere. We often transfer approaches directly from one context to another, but in this instance, the use of rapid insight gathering and iterative testing of the existing La Famille Ideale tools showed us just how critical it is to take the time to adapt properly. Iterations to the game included changes to the visuals, contextualizing the technical information provided, as well as really thinking through how the tools were going to be integrated into existing MSI systems and approaches in each country. Senegal and Niger now have their own versions of each of the tools, the board game and the conversation cards, which they're piloting. These rollouts continue with multiple mechanisms for continued learning integrated into them. These include monitoring the use of the tools through activity tracking and supervision, tracking the number of clients accessing MSI services who participated in the La Famille Ideale activity, and we plan a more in-depth evaluation to explore the impact of the tools on the attitudes, intentions, and behaviors of the young women, men, and community members they're designed to support. Whatever we learn from the pilots, our objective will be to continue to iterate and adapt our approaches to expand access to quality family planning services for adolescents across the Sahel.
Right. That was Georgina Page's presentation. Again, another very good presentation. So maybe, Charles, you could tell me what your best aspects of that presentation were.
I think it was really very clear, and then it really brought out some very interesting points that was emphasized throughout the day. So involving local population stakeholders to really identify what the problem is, and they were part of designing the intervention from the start. I think I really like that about this one. And then importantly, it was an iterative process. So they kept learning as they went along. They tested, got more information. Even while they were in the field, with the prototypes, they kept modifying and learning. And then there was an inbuilt evaluation component where they documented lessons learned. And quite interestingly, even when they got this generic board game, they could adapt it with slight modifications for 3 other settings. And then they had embedded into this an evaluation at the end to see how it works, to measure, what they had set out to achieve. So I think that was really comprehensive in terms of, the whole idea of implementation science.
Absolutely. And I guess when you're setting out to do a research project, you obviously have an endpoint. And sometimes there's a feeling that having iterations may delay your endpoint, but actually there's so much value, as you rightly say, the richness of the information and the intervention in terms of how they've developed it. The endpoint actually is a much more valuable tool for the population that they're going to be working in. And I guess that draws on the fact that actually when you engage people in terms of the acceptability of that intervention, you've actually incorporated all those aspects in that process.
Yes.
And it actually, in the end, shortens the duration of time of getting it to be translated into practice. So absolutely excellent presentation.
Absolutely. And, I think I like the, in the end, in terms of rolling it out, they had this community mobilization.
That's right.
And Sally and I think Imelda talked about the importance of the sort of local implementation teams. So they are known to the local population, and so they've been part of the process. So they can troubleshoot and still learn in that process, even at the rollout phase. So I think this is a very good implementation science project. Designing intervention from the start, learning all along the way, and also having an inbuilt evaluation mechanism.
That's right. Great.
Fantastic.
Yeah, well done.
Okay, so I think we'll now move to the next one.
My name is Victoria Kincaid, and I'm currently a Foundation Year 2 doctor. I will be presenting my Master's and a medical school elective work, which I conducted via my medical school, the University of Aberdeen, and with the charity the Soapbox Collaborative. The title of this work is Implementing a Photo Action Tool, or PAT, to manage overcrowding in maternity wards in low to middle income countries. Overcrowding is defined as the presence of more people or things in a space than is comfortable, safe or permissible. It is pervasive throughout our global society, with the population expanding at a rate that cannot be sustained by the natural resources of the planet. This image is pretty familiar in recent times, with beaches and places being crowded. We can observe overcrowding acutely in healthcare settings throughout the world, where supply cannot meet demand and which compromises patient safety. Current media and research primarily focuses on emergency department overcrowding. However, it occurs in all departments of the hospital, particularly those with a high turnover of patients. One example of such a ward is the maternity ward. Despite this, there is currently no research on overcrowding in maternity departments in any resource setting, nor is there a standardised definition. This crowding is exacerbated further in low to middle income countries, where resources and infrastructure are poor, and demand far outstrips supply due to economic factors, high birth rates, famine, drought, and war. Maternity wards are becoming increasingly busier due to an increase in demand for facility deliveries, with up to 75% of deliveries now occurring in healthcare facilities. This demand, however, has not been met by an equivocal rise in resources in low to middle income countries. Maternity ward overcrowding has a plethora of adverse consequences, both for mothers and babies. Increased risk of healthcare associated infections, neglect and violence from overstretched staff, and unnecessary C-sections, to name just a few. Long term, this may result in women not coming to facilities to deliver. Why is this important? Well, it can lead to an increase in preventable maternal and newborn mortality. Therefore, overcrowding on maternity wards is an important factor to consider if we are to achieve the Sustainable Development Goal 3.1 of reducing global maternity mortality ratio to 70 in 100,000 live births. So, maternity ward overcrowding must have a universal definition and mode of measurement for it to be combated effectively. And this measurement method must be multidimensional to encompass the complexities of the maternity ward. To examine this further, primary research was conducted in a low to middle income country, Ethiopia. Phase 1 of the research was a literature review, highlighting distinct lack of papers describing overcrowding on the maternity wards. Most of the information which was used came from papers based on emergency department. So this is an example of the checklist that was created from the literature review. Data was collected in a checklist over a 5-day period for at least 3 time periods a day, and pictures were taken alongside the checklist as a visual correlation, and that made up the PAT, or the photo action tool. So phase 2 of the primary fieldwork was trialling the checklist on the maternity ward in Ethiopia, and supplementary data was also used. Staff assisted in taking the photographs due to the constraints of language, and consent was obtained in each photo in each clinical area. Then key informant interviews were conducted using a series of questions in relation to what the PAT was basically showing us. This gave us valuable insight into the functioning of the ward and the feasibility of the PAT. So phase 2 was concluded by deeming the PAT was useful in combating overcrowding. So then phase 3 was carried out 9 months later, and that was the pilot study itself. The data was collected 3 times a day for 4 days, and for each interval, basically, it was a 15-minute period where staff and patients were counted on in a clinical area, and then a photo was taken to correlate the data with the checklist itself. After this data was collected, then stakeholder interviews were conducted over a 4-day period, and basically we showed the data and the photographs to see what the key stakeholders had to say. And the pie chart shows the professions of the 8 interviewees. Of the 8, 4 were assigned by the researcher to see the graphs first and then the photographs. So they looked at the data first and then the photographs, and then the other 4 saw the photographs first and then the graphs. The interviewees were very surprised by the issues caused by overcrowding, which the PAT highlighted, but despite this, the interviewees believed that the data they were shown in the PAT was accurate and reliable and presented an accurate picture of the situation on the wards. This is a stock photo, however, it resembles a lot of the photos that were taken by the PAT. One thing that stood out was that most interviewees were shocked by the number of visitors of the ward and the lack of visitor activity. So ideally, a manager could look at a photo like this and see a clear solution to the overcrowding problem. So it was concluded that the photo aspect of the PAT was effective in highlighting problem areas in the ward, such as overcrowding. The photo aspect gives an accurate way of combating overcrowding. However, it's inconclusive whether the photos alone would be enough to stimulate change, but it could definitely be argued that the PAT is effective in raising awareness of the situation and stimulating change, and photographs add a useful aspect to this. So this kind of awareness raising tool is useful in overall helping improve maternal and newborn health, and can be tested in other resource settings throughout the world. I'd like to thank you for listening and would welcome any questions you may have. Thank you.
Thank you. So that was another exciting presentation. Helen, what do you think about that presentation as it relates to the theme of implementation science?
Yeah, I think it just points towards what Professor Sally Theobald was saying in terms of the range of tools and methods that you can use within implementation research. And I guess this one really points more towards more visual. So especially, I think, for stakeholders who may not have direct access or direct contact with patients. And just in terms of an aspect that we've discussed in our session around advocacy and how you can generate that interest in addressing a problem. I think, the researchers have gone through relative iterative processes. I know there's a lot more that can be done just to refine the process, but I thought it was really useful, especially in really advocating for the need for, more infrastructural changes or even processes to ensure that, women are not exposed to these overcrowded situations that exposes them to risks of poor outcomes.
Yeah, absolutely. So, I mean, it's interesting to see some innovation around a tool that can be used to advocate for improved quality of care for women. So still going around the theme of respectful maternity care.
That's right.
So this is a new tool, new innovation. Probably needs a bit more extensive testing, but I mean, it just shows you how we need to come up with, context-specific solutions as part of the whole process of implementation science.
That's right. That's right.
So I think as we begin to wrap up, I want to say that I hope you've all enjoyed, those presentations. We're sorry for the technical problem with the first presentation. We lost sound after 2 minutes, and so you probably did not get the full story from that presentation, and that may be difficult to judge the that presentation. However, the polling is now open. If you go to the polling's button under this session, you have the 4 presentations listed, and I can remind you who is who. So Valentina Actis was the first presentation that was not clear, stopped 2 minutes down the line. Victoria Kinkard was the last presentation you heard about the using photographs. Jack Millen was the second presentation, the one that looked at diabetes and moderate hypertension. And the Georgina Page's presentation was the one on
La Famille Ideal.
Yes, was one on family planning, creating demand for family planning, using board games. So the poll is now open. We will leave it open for the next about 5 minutes, and then we will announce the winner. So we have a prize for the winner. So while you are voting, now after you select, you make your vote, you need to press the submit button, which is down at the bottom. If you can't see it, scroll up, and then you click on the submit. Then your vote will count. So we'll close this after 5 minutes and announce the winner. While you're doing that, we can just give a summary of the day and give some instructions for tomorrow. So we had an exciting session today. We had 2 very interesting keynote speakers, Professor Sally Theobald and Annie Potella from the WHO. We also had, several parallel sessions. One parallel session was on the NHIR group research groups, and we heard from Professor Delia Numba and Professor Tina Lavender. We also had a panel session, where we discussed and looked at key examples, frameworks for implementation science. Particularly, we looked at a systematic approach to capacity building within implementation science. And again, several key points were emphasized over and over and again. The involvement of stakeholders right from the start, having a robust plan right from the start, how you build local capacity, what you put in place to ensure ownership. There was a lot of talk about the importance of it's all an iterative process. there are some trade-offs between, pure science and implementation science. Implementation science addresses, context-specific barriers that lead to, non-uptake of research findings in local settings. So really involving and acknowledging the input of local stakeholders is very important for success. And we heard from the NHIR sessions and also from the presentation from Professor Bates that a lot of the research funders, UKRI and co, NHIR, they really expect you to embed, the concept of community engagement and involvement, engaging the community, and also local capacity building. So these are very important concepts that they will want to see in your proposals. A lot of the slides, all the presentations are there online. They're very rich content, and we will make this available on the website through the app for the next 1 year. So you can really go back and look at these key concepts. And the app allows you to get in touch with the various speakers, and they will be able to take any specific questions you have. Just before this session, we had 3 exciting workshops that looked at practical, research experience from various settings as relates to maternal health. So these are very important learnings that you can, transfer, into some of your future research designs. So tomorrow is the last day of the conference. Again, we start promptly at 10 minutes to 9, yep. I think. Yes, we start. Yes, yeah. So and we have a very rich program tomorrow. I think just in the spirit of implementation science, the iterative process, we have learned a lot from today. So bear with us. Tomorrow will be smoother. I can guarantee that. So tomorrow will be a lot smoother. We have, a very exciting keynotes panels tomorrow. So I will encourage you to log in and participate. Now the polls are closed, and I'm pleased to announce the winner is Georgina Page. So the presentation on how an intervention was developed from grassroots through an iterative process to improve advocacy, communication, discussion within the community about family planning. And we know that in some of these settings, these are not issues that are discussed openly. So, this was almost 4 out of every 10 votes went to Georgina Page, so 43% overall. So congratulations to Georgina. So you're going to get from the conference secretariat your prize, which is an Amazon voucher. So thank you very much. Helen, do you have any closing words for?
Yeah, so I guess I wanted to really say that the audience have been really key to this conference. I think everyone's engagement, the questions that have come through have really enriched all the discussions throughout, the conference. So just to thank you as the audience for your participation. Obviously, this is the first time GLOW has been done virtually like this, so there are many lessons that we will learn from it. But it's been great just really having your engagement in helping us be, succeed at what we are doing here. So thank you very much. And to all the presenters, all the hard work that they've put in recording and then being there to answer questions, it's been fantastic. Thank you.
Excellent. So, big shout out again to all our presenters, all the members of the organizing committee, and the crew. The filming crew, the crew behind the app. They've been working flat out to ensure that we have an excellent online conference. And the participation, from what we've monitored, the interest has been really phenomenal. So let's continue breaking the record, and let's do it again tomorrow. So have a good evening, everyone. Thank you.